didn't like. You know how your daughter can be, and he got it up.
Welcome, Professor Pradankovich. I just put up a lovely little sign for everybody so they didn't get confused.
I like that. How are you, Dr. Bogart?
I'm doing well. Yes, I am.
Good. Good. I've missed you.
I miss you too.
I think you're spending time more in the NUR than you are at the PNR, but you're
Yeah,
expert everywhere.
yeah, we float all over the place.
That we do. That we do. We never know
Yes.
until week 2 where we're going to be at, right?
I have no clue. I might even be teaching pharmacology. Who
There
knows?
you, there you go.
Right. I'm going to take my sign off. I'm going to hand it over to you. And
Okay.
I
Thank
will be
you.
back for these students for
Thank you.
6:45. Thank you so
All
much.
right. See you guys. Or see you, Betty.
Okay.
Hi, everyone. We're a little early. Good seeing you. Goodness gracious, I haven't seen these names since the beginning of the term. So look at there. I'll be joining back in just a moment, everyone. I'm wearing my HESI. Oops, sorry. I'm wearing my HESI hero shirts for y'all, okay? You got my little HESI. Where is it at? This side. It's from HESI for the heroes that y'all are going to be next week. So we have just about a minute, but as I get prepped and get ready, I have a little PowerPoint. So it's going to be maternity first, then pediatrics, and then the last, I think, is mental health for you guys to go through. So I haven't seen you all in a while. So we spent the first 3 weeks together, but we're going to do a little bit of a different review. And as I'm loading up my PowerPoint, well, I'm going to do PowerPoint, but as I am loading it up, the content maybe look a little different. I do still want you to review the content that you've had, but what I did was I went back and looked at some previous um, what has been kind of the concepts that have been on HESI in the past. So I really focused this review on going over some of those contents that you don't often that we don't often get, or things that we don't discuss, but HESI might discuss them. So let me just, since I'm doing it first, I do always want to remind students that HESI remediation is required for everybody, and it must be completed by the 22nd by midnight. Please don't wait that long. What I noticed is most students that really do well, that meet the benchmark of 900, are the slowest ones to get theirs done. But if life happens and you don't get that remediation in by midnight, you will get a 0. So don't do that. Don't give us heart attacks. You get your assignment in, start working on that learning, the HESI learning plan that's developed for you guys, for you, specifically your learning where you scored the lowest. So, and focused in on those areas. The other thing I want to remind you, next week, you won't attend class. You won't come into Zoom. Your HESI counts as your attendance. So once you take your HESI, that we mark that as that you've completed you completed class that day. Now, week 12, probably you're going to meet, and I'm sure the announcements will come, or Dr. Bogart will tell you where you're going to meet at. Okay, so we'll probably be meeting about this time. Well, it won't be this time, but we'll have a special time that'll be in your announcement that we'll meet, and in which Zoom room. And we'll come in and we're going to spend, 15 minutes with you, 20 minutes to go over some of the concepts you missed in your HESI. So just wanted to review that with you guys. I hope you've been doing well. Y'all look great. I've missed you. I did like my Wednesday night class. Y'all were fun. So antepartum. So these are some key areas that with antepartum that we're going to talk about, and some real important that we're going to break down. Definitely go back and look at some of the routine things. They'd love to talk about the second trimester changes. So I have a few of them, but remember in Leifer, in your textbook, there is several pages with normal complaints, common changes, not complaints, common changes that take place in that woman's body. Remember, most organs make changes during pregnancy to support pregnancy.
Yeah, I can hear you.
Hey, Destiny, you got okay. I didn't know if you had a question or you just needed to be on mute. Got it. All right. And then we're going to talk about some different lab works we're going to do. We're going to focus on just the routine assessment, but more on certain things that we're going to assess for. And then some education. Remember, education is always important in our pregnant client. Just to go over some key things. Warning signs during those prenatal visits. What are some of those conditions that we warn that client on? And the importance of nutrition. So Remember the importance of folic acid in pregnancy. It is to prevent neural tube defects. So clients are instructed, especially women of childbearing ages, should have a diet high in folate. And then if they're anticipating pregnancy, prenatal vitamins with folic acid is encouraged. DHA, also important supplement in that in pregnancy, because DHA, the omega-3 fatty acids, are very important in the health of that brain, the brain development of that newborn. So definitely support sorry, DHA, and that is found in they are the fish oil supplements, but also eggs, fish, salmon, red meats, and those protein areas. Prenatal screenings, we're not going to spend a lot of time, but areas you may need to focus in on. Don't forget your GTPAL and how to assess that. And then Nagel's rule. Remember, that is the rule that we use to estimate the date of delivery. And we do that by finding out the first day of her last menstrual period, subtract 3 months, and add 7 days. It's been a long time since you heard me say that. So we definitely want to know how to do that, and you can go back and review. Other key things, lab work. We're going to get those a lab work, and some important things. We're going to talk about the RH negative client and how we treat her with the ROGAM, or the immunoglobulin, at 28 weeks. So got a slide coming up on that. You definitely want to know different statuses. We're going to check her rubella status, and if she is non-immune, remember that's German measles, and if it's contracted during pregnancy, it can, and she's not immune, it can cause serious congenital conditions in that baby. So if I'm not immune, we're going to have her not try to stay away from anybody during pregnancy, but we cannot give the immunization because it's a live virus. So we offer it. The best time for her to take it would be right before she's discharged after delivery. So we'll talk about that at that period of time in that postpartum phase. So at that routine visit, remember, we want to do her vital signs. We want some routines. What are her vital signs? What is her weight? Remember, weight is important. She should gain, if she's of average weight, 25 to 35 pounds. I asked that question. I taught this twice already in the past couple of hours. So, it was all over the board. Average weight woman should gain 25 to 35 pounds. That sounds a lot for our skinny society, but it's normal, healthy. And 1 pound, 1 to 4 pounds in that first trimester, and then a pound a week would it's help to support that woman's health during pregnancy and the health of the baby. We're going to check her urinalysis. One of the key things, and we'll talk about this, is proteinuria. Check them for protein, which is a sign of preeclampsia. Want to know if she has any HSV, if she has any HIV, any conditions that can affect the baby and the health of them. We're going to discuss toxoplasmosis. Now, at 20 weeks, around that 20-week marker, we're going to do a complete ultrasound. That's usually when that first ultrasound is done. So we'll go over that in detail. We always want to check the height of the fundus, make sure that that baby's growing appropriately. And then again, second trimester changes. Always remember that we also have another patient. We see the mom, but our other patient also, we need to assess them, and we're always concerned about them. So early on, fetal kick count. Is that baby moving? So fetal movements are important. We listen to the heart rate with the Doppler, and we know that normal fetal heart rate is 110 to 160. 110 to 160. And that newborn's normal heart rate, 110 to 160. So we follow that throughout her pregnancy and assess it. So got a couple of questions now, and I'm going fast because this is a lot of information in a short period of time. So a nursing instructor is teaching about second trimester changes. Which physiologic changes or change helps the woman distinguish the fetus as a separate person? So not only do we talk about the physiologic changes, what's happening in the body, but also some psychological changes during this second trimester and that adaptation role HESI likes to discuss. So which one might be the most appropriate? That physiologic change that helps the woman separate and distinguish the fetus as a single person. I'm going to jump in and give you the answer so we don't get behind. So it is B, feeling that baby move. This aids in helping her identify that this is a baby and it separates her from herself. The fetal movement usually between 16 and 20 weeks. And remember that term is called quickening. So B is the correct answer there. Excuse me, I got a tickle. Which psychological changes are characteristics of the second trimester? Select all that apply. So resolution of early ambivalence about pregnancy. Yep, that happens in that second trimester, so that's correct. There is going to be an increase in focus in on herself, so B is also correct. Even more like narcissistic, she focuses in on herself, and she also tries on that maternal role. She starts focusing in, I'm going to be a mom. She also fantasizes about the infant's characteristics. So A, B, C, and E are all correct. Introspection, which was D, that is what really occurs in that third trimester. So that's why it's not appropriate there. So this is that physiologic changes. And so again, remember that little cartoon slide that I had all the organs on it, and it had how every system has how it changes. So this is about nosebleeds, and so they are common complaints around that 20 weeks. They get nasal stuffiness and nosebleeds. And what causes that? That is caused by, any guess? Uh-oh. No, usually we're my answering people. So it's been a while since we did OB, but remember those hormonal changes, especially that estrogen affects nosebleeds and increased saliva, but also there's an increase in blood volume. Remember, the pregnant woman has an increase in blood volume by 45 to 50%. And so this can also lead to pseudo anemia of pregnancy, because it takes a little while for the red blood cells to catch up with that increased blood volume that she's going to need because she's going to lose blood after delivery. So that is a normal physiologic process. Now, why would the nursing instructor is explaining routine ultrasounds at 20 weeks? So which of these statements is most accurate for that education piece? So correct answer is going to be B, everyone. B. An ultrasound, again, typically performed around that 20 weeks gestation. And what they're going to look for is any anomalies. They're going to look at the spine and look to see if there's any neurotube defects. Remember, that is the condition that we want to kind of prevent. So we encourage folic acid, but it can cause openings at the upper end, anencephaly, or even at the lower end of the spine, spina bifida. And if we see, and then they're also going to look at the other organs and see if there's any abnormalities. Look where the placenta is located. If it's placenta previa, which is lower lying placenta, that woman may need to be delivered by cesarean. So it gives us a lot of information at what's going on. So the best answer here is B. And so you're again that client 20 weeks and it reveals a cardiac anomaly. So they're looking at the heart, and the nurse explains this finding may influence birth planning because what might affect the way that patient's the planning her birth plan? I'm gonna let y'all answer. I'm gonna wait.
Is it B?
B.
Thank you, Devin. I knew if I waited long enough, somebody would jump on. It is B because of the anomaly may determine where she's going to deliver. So you don't want to deliver a baby with a heart anomaly at a rural hospital, and then we'd have to transport the baby to a level 3 or level 3 nursery NICU, maybe to have a procedure or the C-section there, or in worst cases, you transfer the baby and you leave mom at that rural hospital, and that's hard to separate parent and baby. So yes, the correct answer is B. I know we talked about Rh immunoglobulin. I do have it twice in here. Why? Because we look at it in this antepartum period. We get that blood drawn. We know what mom's blood type is, and if she's Rh negative, she is a RhoGAM candidate, and we give it to her at 28 weeks. So all Rh negative moms get RhoGAM at 28 weeks. It is given IM, and then again, well, they're timing 26 to 30, but consistently or commonly around 28 weeks. And then if there's any other time, there's a potential of bleeding. What happens if the blood mixes, mom starts developing antibodies, which can affect that next pregnancy. And so you want to treat her with the RhoGAM, Rh immunoglobulin. You'll see it also initial RHIMG. I'm sure HESI will spell things out. The other thing we're going to look at is in that post-delivery phase. After she delivers, we're going to know baby's blood type. If baby is Rh positive, then mom is again RhoGAM candidate. In that prenatal period, we don't know what baby's blood type, so all Rh negative women get it. But in that postpartum period, if the baby is positive, that Rh negative mom can develop antibodies if there was a cross of the blood, so she'll get RhoGAM. If that baby is Rh negative, we don't need to give mom RhoGAM. We'll go over that just a bit again. Now, toxoplasmosis. Toxoplasmosis is a protozoan parasite that can cause serious harm to that fetus, including loss, malformations, or other ocular infections in the infant. So very serious condition. There's no testing for it. Main thing, it's about education. So we instruct her to turf the duties of taking care of the cat litter. Have somebody else empty the cat litter box because cats may shed that organism in their feces. Another thing is always wear gloves and wash hands thoroughly after taking care of animals, of course. And if she's a gardener or she's out in the garden or the soil, it can be passed through soil. It can also in the meats and raw meats. So you want to cook meats thoroughly. And of course, you can't say enough in healthcare. Hand hygiene is important anywhere. So wash hands carefully, especially again, handling raw meats, gardening or touching soils, contact with cat feces. Definitely the most important thing is instruct her not to empty the litter box, give that duty to somebody else. Again, it can protect that vulnerable fetus, especially during that crucial period of critical development. And so definitely want to instruct her to avoid emptying that litter box. So here's that question. So the correct answer, of course, what statement by the patient indicates understanding about toxoplasmosis. I should avoid changing my cat litter boxes. Again, we're going to educate the client on this because cat lovers are going to say that's silly. And, so I kind of think so too, but it is important. And we always got to think of the health of that baby. Now, any questions what we've gone through? So it's a little different from what we had in class, but you still have that material and those recordings available for you. Let's talk about that woman going into labor and that interpartum period. So there's several things that we're going to focus in on, especially if that client comes into the hospital setting. So if she comes in, what key things? Some question. What's her gestational age? Is she preterm if she's term baby? How is she presenting? Is she presenting, kind of comfortable having contractions every 5 to 7 minutes? And, she's in that first stage of labor in that latent or very early period, 3 centimeters. Then we can start asking her questions. We're going to assess not only her vital signs, but how our other patient is doing, our baby. So we put her on the monitor, take her vital signs, get a health history. Some of the important things we want to know right off bat, again, if what stage of labor. If she comes in grunting, bearing down, we're going to kind of have to skip and work fast to get through things because she might be having a baby. And we're going to talk about an imminent delivery in just a minute. But we want to know her group B beta strep status. That's one of those screenings we do around 35 weeks, 36 weeks. That provider will do a culture to see if that mom is a group B beta strep carrier. I know y'all remember that. And if she is, then when she goes into labor, we start giving that mom penicillin, giving her antibiotics. We also assess for herpes simplex virus. So we'll do check to see if she has any lesions. So it's real important. Again, we're going to bring that into a little more details, but definitely want to check that if she has a history of herpes. So this section, we're going to focus on some different things. So legal implications, induction, impending or precipitous deliveries, what's abnormal in our tracing, if mom does have infections and treatment of those. So let's talk about something we don't normally talk about until leadership, but sometimes HESI likes to ask us legal. We got to have that full scope of practice, and especially in obstetrics because it is a high risk area. It's a specialized unit of care. So it's very important that you know wherever you're licensed at, in whatever state you're licensed in, that you know what your functions are, what you can do as an LPN and your role at that state, because it may change state to state. I live close to Alabama, work in Florida, but just across the line, 30 minutes away, their scope of practice is a lot different than what Florida is and what you can do as a nurse in that area. So as a PN, as an RN, as a licensed personnel, you need to know what your scope of practice is. If it comes to floating, being pulled to a unit, a specialized unit, again, know your state board of nursing, what your scope of practice is. You cannot work beyond that scope of practice. So they're not going to have you go in and be scrubbed in for a C-section if that's not your scope of practice, if that's not an area you're focused in. But if it's a critical staffing and they need assistance or need support person there, you can go and do that. You can take vital signs. You can change diapers. You can monitor and assess patients. So know what your scope of practice is. If you refuse It is your responsibility to refuse assignments or tasks that cannot be legally done. So you need, again, that's why you need to know what your state board of nursing says. But before doing that, you want to know what you're going to be doing up there. So definitely want to negotiate with that nursing supervisor saying, hey, go up there and what you will be doing. So you want to kind of negotiate what task you can do. You cannot, you were, as I used to always tell the staff when I was working there, you can't refuse to go, but you can refuse assignments. You have to work it within your scope. So you negotiate, but you work for the agency and also know your agency's policies. So this is going to make a little more sense. I do have one or two questions here. So a medical surgical nurse is asked to float to labor and delivery due to staffing shortage. The nurse has no OB experience. So what is the nurse's most appropriate action? What would be your appropriate action here? That's right. Thank you. So C is correct. You want to negotiate with the nursing supervisor and team, resulting in a satisfactory compromise. Again, clarify what you can do and what you can't do, and you can be there, be supportive. And help out as a nurse. As nurses, we all have skills that we know that we're learning now. You don't have to do those specialized care such as this. However, this is a specialized care, but we do need to know a little about doing an induction. Diamond, hi, need you to perk up a little bit. All right. With the patient that's being induced, oftentimes it is inductions are done with oxytocin. It is given IV. It is a safety concern. So usually it's one-on-one care by an RN. And it is the medication is run through an IV piggyback through a pump. The patient has to be on the monitor and has to be monitored. And we're also monitoring the baby. So it's very serious drug and procedure that we do. If there's any abnormalities in that mom in her vital signs, how she's breathing, how she's feeling. One thing about oxytocin is it can cause water intoxication where she starts swelling up, not urinating. And so anything abnormal, we as nurses have the right to stop oxytocin. I don't have to call. You stop the oxytocin because it can be what's causing the harm, especially if it's concerning our baby. So I don't know how much you remember about fetal monitoring. We're going to go over it. So any baby that's heart rate, remember normal fetal heart rate 110 to 160. If it's above that or below that, if she's having late decelerations, if her contractions are way too close together, we're going to stop the oxytocin. Late decelerations are almost always our concern with the with oxytocin. So it is that poor placental perfusion. Uteroplacental perfusion is what causes late decelerations. And I asked you to remember the LION, LION acronym to help you remember your interventions. So always stop that oxytocin for abnormalities. Reposition the client. So there you go, left side or lateral position. Increase IV fluids, the non-medicated line. Give her a bolus of fluids. Administer oxygen, that's THO, 8 to 10 liters per facial mask. And notify that provider immediately. Get that provider at the bedside so they can intervene. So your client's receiving oxytocin induction. Which assessment finding requires the nurse to stop the oxytocin immediately? So HESI does like to talk about induction. And I think you said C, and that's correct. If you see late decelerations, that is concern. That's that baby coding. You're always going to intervene, and so the correct answer is C. So whatever you see when they're talking about monitoring, you see lates, that's going to be our big concern. Stop that oxytocin. Do the lion acronym. There's another one. A nurse is monitoring a client undergoing oxytocin induction. Which findings must be documented and reported to that provider? So, what's abnormal here? And I'm going to speed up just a bit. So, what's abnormal? Those contractions that are lasting 90 seconds. So, prolonged contractions. Mom running a temperature is abnormal. Variable decelerations, even though those are cord compressions, we still need to remember move mom because she can be on the cord and then notify. And then, of course, if she has a urine output of less than 30 milliliters in an hour, we're definitely going to report that. So monitor those vital signs, monitor our baby, monitor her eyes and nose. Herpes. So we talked a little bit about that at the onset of this. So herpes, if that client comes in and she presents with no visit, she has a history of herpes, and we get that in her information, but we do an inspection. If we don't see any visible lesions or prodromal symptoms, then a vaginal birth is acceptable. That provider will check her out thoroughly, and we'll proceed if we don't see any lesions. However, if lesions are present, that baby needs to be delivered within 4 hours from the onset, especially if that water's broken. So this client that has visible lesions will be rushed to the operating room. They're not going to delay and say, okay, it's 3:59. Just the seriousness of that baby contracting HSV. So, but many women are going to receive acyclovir, which is a suppressant. It's an antiviral suppressant, and they start that a couple of weeks before her due date. So around that 36, 37 week period to suppress the an outbreak. But we still, even though she's on acyclovir, you still need to examine her. So timing is important, and that thorough assessment is important. Remember, if lesions are present, a cesarean is required. So a nurse is assessing a woman in active labor with a history of genital herpes, HSV, which assessment findings would indicate the need for a cesarean birth. Yep. You're right. B is correct. Again, visible lesions. If her bag of water breaks, especially, that's kind of urgently. So even early education, telling this mom, you have a history. So at the beginning, if your water breaks, go immediately, or you think you're leaking fluid, immediately to L&D and let them examine you. Acyclovir, remember, antiviral given to these moms to suppress it. So she has no visible lesions and delivers vaginally. Her prenatal records indicate history of HSV. Which nursing interventions are appropriate? So I kept this one. I did shorten this a little bit. So I kept this one because I wanted you to think about what are some important things. So again, we're going to speed through it. The reason why it's not correct is that mom and that infant do not need to be isolated. They're fine. And breastfeeding is safe if there's no lesions on the breast. So she may have herpes lesions in the genital area, but if they're not on the breast, she can breastfeed. Otherwise, the correct answer, infants who are born through infected vaginas should be carefully cultured. And then avoid contact with lesions can prevent neonatal herpes infection. And then some experts recommend presumptive treatment of infants who are exposed. So definitely monitor those babies very, very closely. So the appropriate delivery route is very important. Now let's talk about delivering a baby. So I want to go back to being before we even go in here. When we go and you are floated to a different area, and it's going to happen to all of you. It's going to happen. That just it may not be OB. I doubt if it's going to be OB, but it can be somewhere. I've seen you go to, med surg nurses go to the psychiatric facility or unit, and they're sitters. They'll sit there and watch that client. So you can be anywhere. Again, that's an appropriate assignment. So when you are pulled to certain settings, and especially OB, you want to know key things. And in OB, this is what you want to know. Where's my crash cart? That's a key thing. And in OB, where's the crash cart and the neonatal? So you want the adult and the neonatal crash cart. And the other thing you want to know is where your precipitous pack is, because you're going to be the one running to get the precipitous pack, which is a little delivery tray kind of thing. So if that patient does come in and it looks like the baby's going to be coming out any minute, what that looks like. Um, Comes in saying, I got to push, the baby's coming. These are common terms. Uncontrollable urge to push. Sometimes they're not even talking. They're bearing down, getting that baby. Get that baby out. So the other thing is you'll see increased bloody show and the bulging of the perineum. That head is down in that vagina, about ready to pop out. So do not leave that client. Call for help. If you're in a hospital setting, you're going to push a button. If you're at the mall, you're going to see somebody and say, dial 911 and get me an ambulance. But you're going to stay there. If you have gloves in the hospital setting, you should put a pair of gloves on and then have somebody get the precipitous tray, which is that delivery kit, and then prepare for delivery. So definitely, as that baby's head's coming out, you're going to support it. After the head pops out, you'll have that bulb syringe. You're going to suction the baby. You're going to look for a cord around the neck. That's pretty common. And then you're going to gently support the baby as it comes out, and then keep that infant at the level of the uterus until the cord is clamped. So kind of keep that baby right there so the baby doesn't lose blood if you put it way up high. You don't want to do that. So definitely want to support that. So definitely want to make sure that you do not leave that client. You get your help to you, but you stay with her and support her. So this answer is right there. It is B. Apply gloves and stay with the client while you summoning help. Let's talk about infections. Chorioamnionitis, infection of that lining of that amniotic fluid. A very, very serious condition, and it doesn't always present until later. And you know what? The baby usually gives us more of a clue than the mom does it right at first. So while we're assessing the baby on that fetal monitor, we're going to see fetal tachycardia, that heart rate greater than 160. Oftentimes it's 170, 180, and not a lot of variability. Make sure I'm not running too far till 6:30. So definitely want to look for that. If there's any fetal tachycardia. Another thing, if that water breaks, it's a foul smelling, purulent amniotic fluid. Its often color is yellow, cloudy and yellow, and definitely has an odor to it. The mom also experiences uterine tenderness, and she has very frequent contractions called tachysystole. And so you just go to touch her abdomen, very, very sore and tender. And so because her insides are infected. Mom may show the temperature later, and it's usually very, very high. usually 101, 102. Again, but baby usually precedes, fetal tachycardia usually precedes that temperature, that mom's temperature. So definitely assess for that and report it. And client will be placed on penicillin and usually gentamicin with it. And then oftentimes the baby, as you can tell, these fetal tachycardia, absent variability are signs that the baby's seriously ill. And so they will usually end up having a C-section, even though it's an infected client. So it is very serious. So suspect a C-section going to follow as well, but get that client on antibiotics. Sometimes we'll get that temperature down. So a nurse is caring for a laboring patient whose membranes ruptured 18 hours ago. Another sign, prolonged ruptured membranes can cause chorioamnionitis. What are some of the, which assessment findings would most strongly suggest chorioamnionitis? So maternal temp of 101, yes. Maternal heart rate of 110 beats per minute. Yep, mom has tachycardia. Baby's heart rate goes up, mom's heart rate goes up. So C is also correct. And then E is correct, uterine tenderness on palpation. Remember, amniotic fluid, we assess that whenever it's broken. Clear amniotic fluid with flecks of vernix is normal. That's normal. So again, I put this and I just left it at the end, but know your normals and know the treatment. So that fetal heart rate monitoring our other patient, our baby, our normal baseline 110 to 160 with moderate variability. That's that jaggly line. We love accelerations. That's the mountains on that top line that lets us know our baby's well oxygenated. Our decelerations are concerning, but early decelerations, heads being compressed, remember as it's squeezing through that vagina, causes head compression. It mirrors the contractions, looks like contractions up here. It just kind of drops down, contraction ends, the deceleration. Head compression, document nothing abnormal about that. The veal chop, cord cord compression are variable decelerations. We move mom as our intervention. And of course, we've already talked about the worst one, the lates. Lates always mean a sign of compromise, uteroplacental insufficiency, and we definitely use that LION acronym. Left lateral, IV fluid bolus, oxygenation, and notify. And remember, they're called lates by the way they appear. They occur after the peak of the contraction, they occur after it, and then the contraction ends, and that deceleration is just coming back up. So it occurs late in recovery, too. Poor placental perfusion, treat it with postpartum. Focus in on that postpartum. Everybody remember the bubble HE, right? That's our assessment. That's our assessment in that mom in that postpartum period. And so definitely the breast, the uterus, bladder, bowel, lochia. How much lochia is too much? Definitely going to focus in on that. Episiotomy, Hohenstein. Remember, with Hohenstein, we're seeing if that client has thromboembolism or DVT. So definitely want to assess that early ambulation, and then her emotional status. How is that client? Postpartum blues is common. Postpartum depression is abnormal. It's prolonged sadness, and we need to get that client help and let her and help her as she's coping, because it can affect that also, not only the health of the mom but mother baby bonding. What is uterine atony?
The firmness of the uterus.
Yeah. Thank you, Stephanie. It should be firm. Should uterine atony is a boggy uterus, like a Nerf ball if you're palpating it. Your uterus isn't contracting, so your patient's hemorrhaging. So, what is the key to prevent, or what do we use to prevent, or if we identify uterine atony, what do we do to that client?
A fundal massage.
Fundal massage. So fundal massage is important. So uterine atony is caused by many things. It's a lack of muscle tone, can be caused by overdistension, a big baby, triplets, twins, retained placenta, full bladder, because that bladder can prevent it from contracting down, prolonged labor, medications such as mag sulfate. So a lot of things can cause it. So definitely want to make sure that if we identify it, we want to know where the uterus is. It should be midline and it should be firm. And each day it should go down at a predictable manner. So again, uterine atony, what does it look like? Boggy uterus. Displaced uterus is when that uterus is high up in the abdomen, and that's usually caused by that full bladder. So if we reach down and we feel the fundus is, or reach up because it's up higher, and we feel that fundus is firm, but it's way up here, right up under her rib cage, she needs to empty her bladder. If we see increased lochia, large amount of lochia or large clots, this is abnormal, and we need to check that fundus and make sure it's firm. Then, what are some signs of hypovolemia? So even if that mom's bleeding a lot, things like low blood pressure, hypotension. So we know shock, signs of shock, low blood pressure, tachycardia, cold, clammy skin, decreased oxygenation. All of these are warning signs, and we need to correct this fundus before we get into hypovolemia or shock and lose a young, healthy woman. So, medical management, fundal massage, bladder is displaced, empty the bladder, or the fundus is displaced, empty that bladder. Medications, the most common, oxytocin. We're going to be administering oxytocin. That's just routinely. If we see bleeding, the most common one is the methloginavine or Methergin. Remember, cannot give that to clients that have had a history of high blood pressure, either during pregnancy or prior to pregnancy. So methloginavine, which is Methergin, is very good to prevent or to stop uterine atony, have that uterus contract, but it is contraindicated in clients with a history of high blood pressure. And remember, normal postpartum changes, that uterus should go down in a predictable manner. It should be midline, and each day it should go down 1 finger breadth, 1 centimeter per day. And then the lochia should be it should be rubor right in that first few days. Then it gets lighter, cirrhosis, which is a pinkish, and then by day 10 or day 14, it should be a white creamish color. We also want to observe that lochia for any clots, any bleeding. What is excessive bleeding? So think of the heavy saturated pad. If they are saturating 1 pad or more in an hour, that is hemorrhaging. That's way too much. But one of the important things is we have clients that are taking care of themselves, so they're changing their pad. So we need to ask them, if we go in and we assess and we see this pad, how long? How long has that pad been on? That's real important, because if it's been on for several hours, not that big of a deal. But if it was just changed 15 minutes ago and it looks like that, that's an important, that patient may be hemorrhaging. The other thing I forgot to mention back here when we're massaging the fundus, remember, remember in the textbook, it shows you how to support that uterus, because if it is boggy and you begin to massage it, you can invert it and cause that uterus to come out, and you'll lose your client. Your patient will die on you within a couple of minutes. She'll bleed that much out. So definitely want to support with one hand over the symphysis pubis area while you're massaging. Sometimes they have you demonstrate things like that. So here you're teaching a new graduate about lochia. Which statement by the graduate indicates correct understanding? So the correct answer is C. You want to know when that patient has changed her peri-pad. That's very key to it. So again, they're changing their pads on their own, and if it's if it's bleeding very heavily and it's been an hour or less, then that is something to be of concern. The client with back to the vaccines, remember rubella. We check that mom to see if she's rubella immune in the antepartum period, that initial lab work. If she is non-immune, after she delivers, right before she's discharged, we're going to encourage her to get the rubella vaccine, the MMR. And then because it's the perfect time, and we instruct her not to get pregnant to avoid pregnancy for a month. So definitely want to encourage that. Tdap flu shots can be given during pregnancy. RhoGAM, bring it back up again. Remember, to moms, Rh negative moms who've had babies that are Rh positive. They need to get that RhoGAM within 72 hours after birth. That way those antibodies aren't building up, and this protects that second pregnancy, the next pregnancy. Give it IM and get that medication to them. So a nurse is preparing to administer RhoGAM to postpartum client. Which actions are correct? So A, RhoGAM is given to mothers, not the newborn. The medication is administered by intramuscular injection. The Rh negative mom should receive RhoGAM only if she delivers an Rh positive baby. Rh positive, that's where the antibodies get. And then we do give ID cards so that client knows, everybody knows when her last dose. So it's a continuation on that card that she got her RhoGAM. And these Rh negative moms usually will hand those to you. And so it's only given to moms, not to newborn. Now let's talk about preeclampsia. Preeclampsia, remember, that's elevated blood pressure. It's used to be called toxemia. Can occur at any time after 20 weeks in pregnancy. Very seriously if it occurs in that postpartum period. Women can still die up to 6 weeks postpartum for preeclampsia. So we're going to assess that client, monitor her blood pressure, monitor for any serious conditions. The main thing we educate mom on immediately afterwards, and then also in that postpartum, when we discharge her, she has persistent severe headaches that are not responding to acetaminophen. Any visual disturbances, blurred vision, spotting, flashing lights, and epigastric pain, pain in that right upper quadrant, very, very serious. Decreased urine output is another thing. So definitely monitor our clients for that. In that postpartum period, monitoring those blood pressures as well. Again, upon discharge, patients most know the report. Severe headaches, vision changes, epigastric pain are kind of the most common things. Teach those warning signs. So here's your client. She delivered 36 hours, and you're assessing her. Which assessment findings require immediate intervention?
2. B, whatever that
Yes,
number.
whatever the number is, you're correct. Thank you. Women should contact their OB provider um, or return to the hospital immediately. Severe pounding headaches, blurred vision affects that cerebral spinal or cerebrum, expects the brain. They can have strokes, they can have a seizure, and then epigastric pain, liver involvement. So definitely very, very concerning. So again, another symptom, which symptoms should be patient report immediately in that postpartum client, select all that apply. A, severe headaches, B, blurred vision, and D, epigastric pain. Think have severe persistent headaches. Focus a little bit on that baby. So these are the last things that we need to talk about. So I'm going to speed up. Know your normal vital signs. Respirations that are abnormal, 30 to 60, are normal. They're abdominal breathers. They breathe irregular. They may even pause their breathing. That's normal. Anything greater than those respirations, any grunting sounds, cyanosis, central cyanosis concerning, seesaw respirations. These need to be reported, okay? We know acrocyanosis is normal. When we assess that baby's respiratory rate, remember we're going to observe, and that's what we're going to do first, and we're going to assess it for a full minute. So the answer to this question is a full minute. You want to make sure that you get them in that quiet state, and you want to assess first because any activity may cause crying. So your newborn is assessed a 6-hour-old newborn respirations. Which findings require further evaluation? So again, anything abnormal, and that is that consistent respiratory rate of 60 breaths per minute is abnormal, and also asymmetrical chest movement. They should not be one side. That's seesaw respirations, and that's abnormal. The baby in the delivery room, a couple of more things we're going to talk about. Giving that baby erythromycin ointment. That erythromycin ointment, we know the vitamin K helps with promoting clotting, and then the erythromycin ointment is given in that first hour. Can delay up to 2 hours if that baby's bonding. But what we're trying to prevent is ophthalmia neonatorum, which is conjunctivitis in the newborn. And it can be caused by gonorrhea or chlamydia. And so treatment, if treatment is not given, this can lead to blindness in the baby. It's a silent condition. So we definitely want to treat that client in that 1 to 2 hour period. And if that client refuses, so I put this in here, this was on the little thing that I got from. But if that patient refuses, some states, well, you always are going to get them to sign a form. And remember, this is a state law, so they may be special forms that they have to sign. You would check with your agency or your state law. So again, the nurse is preparing to administer erythromycin ointment. Which statement about the timing of the medication is correct? So B is correct. In that 1 to 2 hours, you don't want to delay it. Let's talk about peeing and pooping. That baby, that newborn assessment, they should void within the first 24 hours. You should see urine from that baby. If not, this is abnormal and needs to be reported so they can see what's going on. Oftentimes right at delivery. So we do eyes and nose on our babies, and definitely going to report that first void. The first stool, meconium, it should pass within the first 24 hours as well. Remember, meconium is a greenish, tarry consistent, greenish black, even very dark, very tenacious, hard to get off. This is normal. This is normal. And then the progression of that stool should be, it goes, especially breastfed babies, it goes to a bright yellowish color, and there is between days 3 and 6 they'll have numerous stools. So if they do not, and we again document our timing of our stools and our void, and then if we do not see either one in that 24-hour period, we need to report that. So that newborn, 12-hour newborn, the main thing is to continue to observe in that for 24 hours. So B would be your correct answer. Black tarry stools, again, that's normal. It can be scary, so we let our parents know this is normal, and that is called meconium, normal. Something we may not have discussed a lot, but the genitalia, checking that, especially the females, those little girls can develop can develop pseudomenstruation. This is a normal discharge, and it is as that baby is withdrawing from that mom's hormones. So swelling of the genitals is common. Pseudomenstruation looks like she's having her period. You'll see little blood streaks on that in that diaper. And increased estrogen in pregnancy. You'll also see increased vaginal discharge, and they may even have developing little breast or little breast buds. Common again as that baby is withdrawing from the mom's hormones, estrogen. So parents express concern about their 2-day-old daughter's appearance. The nurse should assure them that at which findings are normal responses to maternal hormones. So again, A is correct, B is correct, C is correct, and E is correct. And that is, everything is correct except the D. Fever is not. So again, it's as they are withdrawing. So here it is again, pseudomenstruation. Correct answer there is B. I think this is our last slide, I believe. Jaundice. Jaundice in the newborn. We want to assess it. We assess it by its yellowish discoloration, most common in that second to third day. We check by compressing on those bony prominences. We push down. When we let go, release, we see the yellow coloration of the skin. Main thing is treatment. Bilirubin is excreted through pooping. And so the best thing we can do is encourage breastfeeding because colostrum is a natural laxative. These babies are going to be placed under a billy light. Whoops, that was it. Under a billy light. They need to have their little eye covers on while they're under that billy light. And so some education pieces that students need to know: have your photo equipment available there, protect their eyes, give parents any materials or handouts, and talk to them about feeding. They need to feed frequently. They don't sleep through feeding sessions. Again, the more they eat, the will help with excreting that bilirubin. So colostrum promotes stooling and with elimination. So here's a question. You're assessing a 2-day-old term newborn with jaundice. Which assessment technique should the nurse use to accurately evaluate for jaundice? So the correct answer: apply pressure to a bony prominence, release, and observe for yellowish color before capillary refill. So it turns yellow. That skin turns yellow. So definitely notify that. They'll put the baby under phototherapy. So your nurse teaching your client about phototherapy for their newborn. Which statement by the parent indicates understanding of the treatment? And so correct answer would be both. It would be B. Phototherapy can safely be interrupted for feedings, parental interactions, assessments, and you can take their little eye patches off. Of course, you need that for bonding. When they go back under the light, definitely want to protect their eyes to prevent any blindness. So, definitely want to do that. All right, everyone. It is, yay, I did shorten it up some. Let me see when your break is over. Y'all are P1
It's
at
6:45,
6:45.
and I'll
6:45.
be there. So I will see you all at 6:45. Have a nice little break.
Bye, y'all. I wish you all well.
Thank you.
Thanks.
So is everybody ready now to do a little bit of pediatrics? We're going to do it a little differently for y'all. So how was your first lecture? I listened to bits and pieces of it.
Was good.
Yeah, I was listening to it, their explanations, the questions, and I think that was pretty good. So I'm doing something different. I am not going to give you a death by a PowerPoint. What I have done, I have gone and looked at previous HESI. That means last term. And I've looked at the concepts that are on that HESI. I've also gone back and looked at just the regular PN HESIs, looked for concepts that are there that were repeated and repeated. And I have made a 50 question Kahoot that is going over the concepts. Now, I have given you all and sent you the PNR142. That's your test study guide. You have that. That's all your exemplars, and it's a very good thing to review. I've also sent you a second thing, and that is your PN HESI NCLEX review. I've actually taken that book and all of the stuff and put it on a PowerPoint. So it has everything with HESI hints, et cetera, et cetera. So I've given you 3 different ways to review for this exam. So whatever works for you, okay? So Destiny, can you come on camera for me so I can start my Kahoots? Miss Van Hook, can you come on camera, please? Let me go and I'll come back to her. As I said, this is brand new. I have just made this. You will be getting the link. Yes, it'll be given in your announcements with the recording. As soon as I get the recording, you'll get posted quickly, okay? You'll have everything you need. Now, I think the one thing that scares you guys is coming on Kahoots and getting wrong answers. I don't look at Kahoots to look at who answers right or wrong or who missed a question or two. This is something I make for you to test your knowledge. And then as you're going along, make a note, hey, I've got to look at this theorist, or oh, the growth and development toddler I need, or what about diet? And then you give yourself little notes as you're going along, and that will help you to study. It can focus your studying in. Thank you, Destiny, for coming on. Appreciate it. Anybody else is going to join me? Appreciate it. Let's have some fun and let's see who's going to win this one. Who wants to win tonight? And I know you're all tired, but does somebody want to win? Swit, I think you do. You're smiling at me. Miss Stephanie, yeah, you could do this. I know you can. All right, let's get going. Let's see how it ends up. Good luck, guys. Do your best and listen to the way I explain these concepts here. A multi-select. Which are appropriate nursing actions when providing care for a child with a submersion injury and hypothermia? Submersion means they drowned. So what happens? That child, it could be adult, goes underwater, swallows the water, and stops breathing. What is our deal here? Well, I can always tell you it's going to be an airway. This is all about airway. The water's in the airway. So with these, you want to have the airway open. You're going to monitor the consciousness. And then if they are cool, there is a heating blanket and there is hot packs and whatnot. And we warm them slowly, not fast. If you think about it, if you warm, you vasodilate. Blood pressures will come down too quickly. You could go hypotensive. So we warm very slowly. And of course, are they alert? Are they oriented? That level of consciousness. And we do want to make sure that they're getting their oxygen there, because what has just happened is they have been hypoxic and the lungs don't like it. And many times these children end up ventilated in intensive care 2 days later. Sometimes it's a delayed effect from a submersion or a drowning. Nursing care for a spina bifida patient includes, do you remember what a spina bifida is? That's when the spinal column and the meninges are pulled up and out on the lower back at the lumbar area. It's that big purple blob looking thing, right? The big thing about anything born on the outside of a body, one of them being that spina bifida, that big purple sac of meninges and spinal nerves, okay? We have to protect it, okay? The inside is on the outside, so we need to cover it with a normal saline, sterile, and sterile dressing on it and preserve the skin integrity around it. So now we can close it back up. Another multi, which are important nursing interventions for a CAS care. So your kid fell down and hurt himself and went to the ER and we had to put a cast on. He's got a fractured wrist. So whenever we take and put a cast on an arm, a leg, a finger, a toe, it doesn't matter. Our biggest concern is there swelling going on and is it preventing blood circulation? That's the whole thing, blood circulation. So neurovascular check should be hourly for the first 24 hours. Checking distally. So if the arm is covered in a cast, we're going to check those fingers. That's the distal. Or on a foot, it would be the toes that we'll be checking. Also, putting your finger in the cast. Is it too tight? If it gets too tight, it's compartmental syndrome and could cause a decrease in circulation and could cause necrosis of those distal toes or fingers. And I have seen it happen. So it does. A multi-select. Nursing care for conjunctivitis. What's conjunctivitis?
Pink eye.
Pink eye, yes. And it's always some sort of bacteria. This is never a virus. I worked with a lot of children with conjunctivitis, and the whole thing is now, how do we care for it? First of all, we have to clean those eyes. So a lot of them are crusty. So we don't want to just try to, rip off the crust. You're going to get, your eyelashes and whatnot. So warm compresses, that will loosen it up. And then rubbing it from the inside out, one tissue one on one side and one on the other one, because that you don't want to cross contaminate. And then we're going to put those eye drops in. The other thing that this question does not mention is, what about if we put in, not the drops, but we have, the cream, the ointment. That ointment is going to make that child blurry vision. Warn the child that that's going to happen. Or they go, oh my God, I can't see. I'm all blurry. And you don't want that to happen. The other thing I tell parents is to change the pillowcases every night so they don't go back into bed on the same pillowcases with the same bacteria that will get back in the eyes. Nursing care for psoriasis. Psoriasis is a really tough thing to take care of. It's a dermatitis on steroids, and it really is difficult to manage. So the whole thing about psoriasis is that we need to keep the skin moist so it doesn't crack, so it won't bleed, so it won't open for infections, okay? We absolutely cover them at night, whether it's on the hands or on the feet, putting lotion on that, putting socks or gloves on. That really helps. It keeps them moist. Also, to be healthy, which means proper nutrition. And whatever causes psoriasis, it is a stress related thing. It's sort of like an immunosuppressed type thing. So, again, avoid the triggers, which could be just stress. Another multi, correct nursing care for restraints. Do we restrain our children? Years ago, when I first started nursing, posy restraints, wrist restraints, even ankle restraints, commonplace. And what happened is a lot of patients ended up with losing arms and legs. They even hung themselves on posy restraints trying to get out of bed. So, do we use restraints? Well, the answer is we're going to use the least amount of restraint as possible. In children's, probably the biggest restraint we use are elbow restraints so that they can't like reach the face, that's something to do with the head. That's about all we do. And the other thing with restraints, anytime you use them, there's always going to be special forms. And it's going to tell you to offer the bathroom or nutrition, to look underneath, making sure that the neurovascular signs are there, to rub underneath, making sure there's no rubbing and abrasions that are going on. I know that whenever I had to use a restraint, I had to notify the nursing supervisor. That's how serious they do not like restraints at all today because of those things I told you about. Which is the primary nursing intervention in the care of a client with burns exceeding 20% of the total body surface area? What do you need to do? Patient comes in and they're burned, 20%. Primary, which means the first thing. What are you going to do? The biggest thing with burns is you've literally eaten up part of your skin, which is a lot of fluid. The biggest thing is fluid replacement. And there's this whole, scenario of what to give the first hour, first 6 hours, and then maintenance, depending on how much of the body is burned. So fluid resuscitation, because you have literally burnt the fluid out of the body with burns. What are some treatment options for diaper rash? Do we have to be worried about diaper rash? Probably this is the biggest thing that causes infants to wake up at night and wake up parents, is because they have a diaper rash. So, frequent diaper change, use either the diaper cream or ointment, whatever that baby likes best, and whether it's zinc oxide, petroleum, A&D ointment, Desitin, whatever the name is, use them, absolutely. Also, we're just going to give them a normal bath with soap and water and just dry them well. Post-op for correction of a club foot. What do you do? Club feet. So when the ankles are not formed right, they can be outwards, inwards, upwards, downwards, but we need them in a place where that child is able to walk. So sometimes we have to do surgery to get those ankles and feet in the correct position. So again, it is orthopedic surgery on an ankle. So you're going to elevate it. You're going to do, those checks, neurovascular checks. You're going to check for swelling. And of course, ice is going to decrease that swelling. A multi. What treatment should a child in pain with juvenile idiopathic arthritis have? Pain treatment. What do we give? You know, I have rheumatoid arthritis. So this is something that I know very, very well. And when the body attacks the joints of it, there are times where the pain is horrendous. They recommend NSAIDs as the drug of choice for pain. But children, you know, there's a lot of different things we can do. Now, I do not like hot when I'm in pain. Give me ice and I'll be slathered in it. Again, a child will like either or. Ask them what they like. And of course, distractions, whether it's an iPad, play a game, play cards, color something, watch TV, or the nurse is dancing crazy in the room with music. All of those things do distract that child and do help with pain. The most essential goal of care for a child with JIA is, what's our goal? You have a child who has idiopathic arthritis, means the joints are being attacked by its body. What is our goal of care? The whole thing is to prevent deformities. Ever see a person with an older person with rheumatoid arthritis, their fingers are crooked and their thumbs and fingers go the wrong way? That's what we're trying to prevent. And if we could get them exercising and keeping them in motion and keep that pain decreased, we can prevent those deformities. What test confirms childhood leukemia? What is leukemia? It's a cancer of the white blood cells, right? What else does leukemia do? It attacks red blood cells, so you're going to have low hemoglobin. It also attacks platelets, so you're going to be bleeding, right? So a CBC is going to give you an idea that the white blood cell count is low, right? But to confirm it, you've got to do that bone marrow aspiration. And then we could say, yes, these are the cells. Are they an AML or ALL, or what type of leukemia is it, so that we can treat it properly? Common symptoms of childhood leukemia include remember I told you, your white blood cells are low, so you can get an infection. Your red blood cells are also attacked also, so you have low hemoglobin. And it also attacks platelets, so you'll be bleeding. So fatigue, right? Low red blood cells, I don't have energy. I don't have oxygen and iron in my blood. Bruising, platelets are low, and then bone pain is very specific to leukemia. A friend of mine's daughter had leukemia, and one of the symptoms was very bad knee pain that continued throughout her treatment. The term strabismus means, what's that? There's amblyopia, there is nystagmus, and there is strabismus. Which one is which? Strabismus is when the eyes cannot focus, so they go cross-eyed. We go and we look at a point and our eyes adjust. A child with strabismus, their eyes will cross. They can't focus like that. Amblyopia is when you have a lazy eye. And nystagmus is that rapid, irregular eye movements, if you were wondering about those. Symptoms of a urinary tract infection in children. So children who don't feel well, number one, stop eating. And urinary tracts, usually there'll be a little bit of fever with it. And of course, that urine is not going to smell right. You're going to see that urgency and frequency that's going on with it. What is the first step in treating a urinary tract infection? What do you have to do? Now, urinary tract infections are never a virus. They're always a bacteria, just to let you know. Like pneumonias could be viral or bacteria. Upper respiratory is the same. So just to know, urinary tract's always a bacteria. You usually have a fever that goes along with it. And treat is always an antibiotic, okay? And we can do that urine's culture and sensitivity, finding out what the bacteria is, but we have a pretty good idea, the antibiotics that cover most of them. So that's usually what we'll order. UTIs are most common in children between the ages of what? Think about what children are doing at these ages. We have infants, then we have toddlers potty training, and then we have preschoolers that may be finishing potty training and now going to school, and then we have school age children. So urinary tract infections are those toddlers. Think about you have a child who's potty training, and then they're wiping themselves, making the stool go up to the urine and those things. And that's what happens at that time. So ages 2 to 6 are the most common, the younger kids. Multi. Side effects of spina bifida include, what would you see? So that's that myelomeningocele, that big purple blob where the nerves have been pulled and the spinal column is on the outside of the body, right? So what are we going to see? Well, the nerves in the lower extremities have been pulled and stretched, and probably there's paralysis, whether it's partial or complete. I've seen them both. And then you have problems with the urine and the bowels. Many children with spina bifida end up needing catheterization every 4 hours because they don't feel it, they don't know. And also the bowel, the same thing. They don't feel it, they don't know when to push. So again, you have to monitor closely bowels and the urine that's going on in those children. True or false? Myelomeningocele is a type of spina bifida and it affects the spinal cord. So the answer is absolutely yes. A major cause of respiratory distress in infants and young children is what? Infants and young children. So infants and young children, our biggest thing is respiratory syncytial. For me and you, it's a common cold, and it's not that bad. But if you think about young infants, they have a hard time suck, swallow, and breathing. Put a little bit of mucus in their nose, and they're obligatory nose breathers. They can't breathe, and that does cause respiratory distress. That's why this virus, respiratory or RSV, is what we look at for children as a major cause of respiratory distress. Respiratory distress in a newborn is manifested by, what do you see in newborns? In newborns, you'll have all the symptoms that an adult has. You'll see the tachypnea, tachycardia, the retractions, abdominal breathing, but infants, their noses will flare. And then at the end of a breath, you hear a If you ever see an infant, a young newborn, that's grunting and nasal flaring, this child is about to code on you. Get the respiratory tray in there to intubate because it's going to happen quick. It's a very scary infant. What immunization helps prevent pertussis? So it's the DTaP. And remember, we give that at 2, 4, and 6 months, okay? And it will help prevent pertussis. Remember, pertussis is a respiratory disease, very, very contagious, and infants get extremely sick by it. That's why we do give it so early in their life. Which of the following is a common feature of vesicular stomatitis in children? What's stomatitis? And it's like the little vesicles, a type of rash type thing. So stomatitis is when you have those blisters or sores around your mouth, inside your cheeks, and it's painful and it hurts. It affects them from eating. They have to be careful what you feed them because it will burn them. So stomatitis is all about, those sores inside the mouth and the cheeks and around the mouth too. What is prescribed in the treatment of stomatitis as rescue therapy? How are you going to treat that? So this is the question. Stomatitis is an inflammation, the itis. Is it bacterial? Is it viral? What is it? And the answer is usually it's some sort of bacteria. So what we do is we give an antibiotic, sometimes topical and oral, and it hurts, as I said, right? So some sort of NSAID or analgesic, or alternating ibuprofen with acetaminophen. And then the steroid helps decrease the swelling, which is causing the pain. What is a possible cause of enuresis in children? What is enuresis? Do you remember? Bedwetting on a child who has been dry. Again, it's a word. Now you're going to remember it. So the thing about enuresis, it could be a medical thing. Could be diabetes insipidus, diabetes mellitus, urinary tract infection. Yeah, we'll rule those things out. But it also could be due to emotion, stress. It could be like my daughter has the tiniest bladder in the world. Don't ever take a car ride with her because every hour she has to stop, even if she's not drinking. And there are children who go to sleep and they don't wake up. They're so sound. So that can be the causes. Nursing interventions with a patient with epiglottitis would include So epiglottitis is what? Remember, the epiglottis is that leaf-like structure which covers the trachea when you swallow, so that liquid doesn't go in your lungs. With epiglottitis, it swells up and it covers the trachea and you cannot breathe. It's inspiratory stridor. I can't get air in. So what is the priority intervention? And what you have to have at bedside is an intubation tray or a tracheostomy tray. You need something there to maintain your airway. And you're not going to suction and cause any more swelling in the mouth. You would not put anything in there. What are typical signs and symptoms of epiglottitis? So you've got that epiglottis swollen, covering the trachea and the back of the throat. And it's all of a sudden you get a fever. And then, of course, your throat hurts because of all that swelling. You're going to be drooling. You'll be in a tripod position like an old lady trying to find a way how to breathe, get air in there. And it's inspiratory, Strider. I can't get air in. And if this child tries to talk, and it'll be all garbled like a frog sound because of all the swelling in the back of the throat. What is the first line treatment for acute epiglottitis? So we know we got the airway stuff in the room, right? Now, what do we need? So our big thing with epiglottitis is an airway protection. You know, epiglottitis was croup that wasn't treated. And then that swelling progressed and now it's covering, the trachea. So first line treatment, we're going to be giving aerosols, right? We're going to do something to decrease swelling. And that's racemic epinephrine aerosols. That inhalation goes directly and that touches the epiglottis, which will decrease the swelling and hopefully will allow for some breathing. What do you do if you suspect poisoning in a conscious child? Child's awake and alert. You think they did something. They took your pills that they shouldn't have took, or they swallowed some cleaning liquids or whatever. So we do not today, we don't believe in vomiting. We don't believe in Epicac. Years ago, when I first started nursing, that's what we would do. But we found out sometimes vomiting created more irritation and more damage than just leaving it in the stomach. So poison control has the most up-to-date information, and they actually will call the emergency room where the child goes to and follows up, making sure that they have the most up-to-date information to care for that child. Anabolic steroids present what side effects and health risks to male teenagers? Kids today, adolescents, they're fighting so hard to get college scholarships, in sports. So they do this anabolic steroids to build up their muscles, right? There's a big problem with it. What are they? What happens is their testicles shrink and they get little breasts. And with these anabolic steroids, one of the biggest side effects is aggressive behavior. This will be a very mild child with no problems, and all of a sudden they're yelling and they're arguing with everybody. That's the aggressive behavior that you would see. Recommended diet for celiac disease. So celiac disease is a problem with gluten. No, wheat, rye, barley, they include oats in there. It's not really oats, but there's usually some cross-contamination. That's why we usually say it. So the problem is that they're not digesting fat, and it creates these big, bulky stools. So fat is very high in calories. So we need to replace that in their diet. So we give high calorie, high protein, and we decrease the fat because they're not going to, take it. It's not going to be used. It's only going to cause gas, distension, and bulky, very malodorous diarrhea. So that would be the diet. We usually would say offer rice to these children to be a choice. There's rice bread and rice cereals. All of those things do work. The rest on those children, no. What are signs and symptoms of hypoglycemia in children? So, children whose blood sugars are low all of a sudden become shaky, irritable, even their vision's affected, shakiness, sweating. Those are things what you would see. How do you treat hypoglycemia in children? Well, does it depend if they're awake or if they're comatose, right? If they're awake, give them orange juice, give them some milk. If they're comatose, it might be glucagon or maybe a D50 amp or some glucose IV in some manner, right? What are the symptoms and treatment for hypoglycemia? So children who are hypoglycemic, they're shaky, they're sweaty, they're confused, they're dizzy. And what do we treat it with? We're going to give sugar of some sort, whether it's milk, a juice, a sandwich, a something, a candy, whatever there is, let's get that blood sugar up quick. And then make sure they get some protein in them because that's how they maintain blood sugar. It's not just sugar, sugar, sugar. True or false? Antibiotics cure RSV. Respiratory syncytial virus. Antibiotics cure it. And the answer is it's a virus. So antibiotics are going to do absolutely nothing for this child. Remember, RSV, we try to prevent it with that injection. It's a monthly immunization called Synagist, only the first year of life, winter to early spring. A multi. RSV treatments. How do we treat RSV? RSV, these are your young infants. It's all that extra mucus on these children. So RSV is all about a virus and extra mucus in the upper airway. So you're going to suction it out. You also give humidified oxygen to give moisture so that you can suck it out and it will come out easy. And palivizumab is another name for Synagist. Now, are we going to bottle feed this child? It depends if they have the ability. Some we can, some we can't. Some we have to tube feed, some have to have a bottle and a tube feed, depending on how much mucus and how much distress that child is in. Treatment for RSV. What do we give? It's a virus. What do you think? That will answer the question for you. And it's ribavirin is the name of the medicine that we do. It's an antiviral, that's the RIN on the end, that will treat RSV. Remember, azithromycin, augmentin, they're antibiotics. And a cyanide is used for TB, tuberculosis. The nurse screens for scoliosis by assessing for what? With scoliosis. So scoliosis is that S-shaped curvature of the spine. Usually we see it when the child starts growing at that pre-adolescent growth spurt. And what we see in this child is all of a sudden you'll see one of the shoulders up. So if it's curved, you'll see one up and one down. The problem with scoliosis is that it's pushing against the lung. So how do we treat scoliosis? Well, depends on how big the curvature is. It might be a brace and exercises, or it might be surgery. What intervention is appropriate for a nurse assessing a pre-adolescent child for scoliosis? So we already know the shoulders are different, right? We've already identified that. But when you bend them over, you can see the back. It'll be curved. And that's what we look at. And it has to be undressed. It has to be naked to see the back for that. Adolescents are all about body image. Erickson describes this as what? Make sure you review your theorists. Adolescents, remember, they're all about body image. They're all about who am I going to be when I grow up, right? So it's identity versus role diffusion. Let's go over these quickly. Industry versus inferiority is school age. And the industry is their factory, it's their product, it's what they do well. Children, school age children, love to please and I like to do something really good and get that strokes from people saying, oh, wow, you're amazing. Now, you can't do everything well. That's the inferiority. That's how you remember school age. Initiative versus guilt, that's your preschoolers. They're trying to do things, but not right. Then they feel guilty about it. And then autonomy versus shame and doubt. Think about autonomy as automatically me, mine. That's a toddler. Me, mine, autonomy. And the shame and doubt is when we as adults don't let them try to do things, being that helicopter mom, helping them put their clothes on, their shoes on, making sure they don't fall and be careful and don't do this. And you've got to let them go and let them do it because they are the explorers. According to Erickson, blank is the most important stage in the lives of infants and toddlers. So, trust versus mistrust as infants. And what is trust versus mistrust? When you have an infant, that's their first, with people and their first response to how people treat them. When they trust, they know, they cry, somebody's going to feed them, burp them, change them, hold them, whatever they want. The mistrust is when an infant does not get their needs met. We see this a lot in abusive households or with drug or alcohol abuse, homelessness sometimes is because they can't get there all the time. So trust versus mistrust, important. That's what sets the child up for the rest of their life. Activity for a hospitalized school-age child. The one thing about school age children and giving them work, you need to give them something that's challenging, but something that they can accomplish. Remember their industry, they want to do things well. So you got a child school age who's going to be in there for a while and you give him an activity. You wouldn't do a paint by number that a 2-year-old would do. You would do a paint by number with a little bit more work to it, but it still can be accomplished and won't be frustrating to them. A nurse teaches a parent about a toddler's diet. Which statement indicates understanding? What do you know about toddlers? Besides, they're the pickiest eaters of all. They've gone from being an infant and eating anything and eating like pounds of food and drinking. They become a toddler and they don't want to eat. They don't want the food. They don't want to even try it. So they only need 1 tablespoon of solid food for every year of life. I think that's an important thing to tell parents because they think that they need more, but knowing that that's what they're getting, then they can calm them down. I know that happened with my husband and my first grandson. So he's not eating enough. What can you do that's good for your toddler's diet, quote, safety? So remember, toddlers, they don't like to eat a lot. And what we say is don't let them have milk or juice before they have their meal. That should be afterwards. They should have soft foods, not a lot of sugar in it. And also, if you're going to give them things that are hard, it should be later on, like pieces and little small, tiny little pieces of it, because our concern on a toddler, ages 1 to 3, is choking. So we don't want too hard or too big of pieces for them. What is the priority treatment for sickle cell crisis? Sickle cell. Sickle cell crisis. Excellent, guys. This is the problem where the cells get stuck going down the blood vessels in a bifurcation and blood can't go down. This little sickle cell just covered it up, and now all the cells behind it are packing up and it's getting swollen and it's causing pain and redness, etc. The treatment is let's get those blood vessels big and dilated so we can get those cells going again so we can decrease the pain. So IV fluids is number one. You would also put heat on it also with it because that dilates the blood vessels and it will get it going. The treatment for a conscious choking child is you should always review CPR when you go into a HESI. So always be a question. Is it 15 to 2? Is it 30 to 2? Do you give breaths? I mean, how do you choke? How would you do it? Is it back thrust, abdominal thrust? What is it? So when you have a child who's conscious, you give them 5 back flows and then 5 chest thrusts, repeated one after the other until we get that out of them. The treatment for an unconscious choking child is unconscious now. So this child's already unconscious. Just start CPR. There's something to cut the kids out. We really need to start CPR and get them oxygenated and get that blood start moving around. Another multi. What are the signs and symptoms of dehydration in young children and infants? I mean, we could look at dehydration in any age child and we would see tachycardia, we would see hypotension, prolonged capillary refill, decreased urinary output, decreased sensorium level of consciousness. But in children and infants, the young ones, we're also going to see some other things. And what we're going to see is that crying, no tears. I think the saddest thing is to see an infant crying and there's no tears coming out them. Also, you're going to see the eyes are sunken in. You'll see the eyeballs also sunk in. Also, that fontanelle, I love infants because I can see hydration status just by looking at their anterior fontanelle. If it's sunken, oh, we're in trouble. Next thing I'm going to do is listen to a heart rate. Let's see how badly dehydrated they are. And of course, you're going to see that dry diaper for whatever amount of time. They usually will urinate all the time. Pyloric stenosis. Usually happens between 3 weeks and 3 months. The sweet spot, I'm telling you, is 7 weeks. So pyloric stenosis, this is when the stomach, where it goes into the small intestines, the pyloric sphincter is thickened and muscular and closed, and milk can't go down. A multi. Hypertrophic pyloric stenosis symptoms. So if you had a child who had a pyloric stenosis, that sphincter is tight and muscular, what would the kid show you that they had it? So with pyloric stenosis, as I said, these children are 3 weeks to 3 months, and I'm telling you, the most of them that I've seen, 7 weeks old is usually that number that I see most of them. What they come in with is, you see this infant, the first thing I ask them, okay, they're vomiting. Is it a dribble or is it across the room, projectile? Once they tell me it's across the room, you can actually, believe it or not, take an infant, turn them around as they're vomiting. 10 feet away, they will projectile vomit into a garbage can. That's how far this projectile is. It's quite impressive, to tell you the truth. So once they tell me it's projectile, I'll tell them, please don't feed that child anymore. But then I'm going to take my hand and put it right under that xiphoid process. And I can feel that pyloric sphincter. I can feel it. It feels like an olive or a little marble. It's hard, this little thing. You're like, oh, that's hypertrophic pyloric stenosis. And because the milk can't go down, yes, they're going to lose weight. Current jelly stools is intussusception. It's when the intestines suck into each other like a telescope, and a little bit of the mucus comes out of the anus. That is current jelly stools. And last question. When taking a health history from an adolescent, the interviewer should what? So adolescents many times will not talk in front of their parents. I know if I was going in with a sensitive subject to the doctor, I wouldn't say anything in front of my mother because I know I'd be beat up in trouble and I would be placed on restriction for a year. So how do we take care of that adolescent? Well, we can ask the parents to leave. Now, we can ask all this history. We do not have to tell the parents what they've said unless that information, that child's going to hurt themselves or others. But besides that, we do not have to divulge to the parents what they talked about. So it gives them a free place to be able to talk honestly so that we can do proper medical care. All right, let's see how we did. Who won today? We got an S for number 3. Number 2 is a big long number. And number 1, drum roll, Stephanie, you said you would. Good job. And then a J and a Jessica. All right, guys, you will see in your announcements, you're going to be seeing on Friday night at midnight, you're going to see an announcement comes out, and it's going to tell you the time to meet me for 30 minutes or less. You need to come on week 12 for your attendance. It's the whole class. So if you're this close to 20%, please do not miss this, okay? Now, If the time that I give you does not work for you, we can meet at another time, but you have to let me know, okay? I have sent you all this information. I will be sending the recording tonight because that's the way I do it, the same day. And I'll be sending you the Kahoots that you can practice also if you like to. I would suggest that you go through that PNR 204 HESI NCLEX review. It really goes over his HESI hints, HESI hints. I would just do all the HESI hints, and that's really going to help you. Well, I'm going to let you go. You're going to come back at 8 o'clock. Yes, I'll give you a couple minutes back because I know you need those couple minutes. So come back at 8 o'clock and Professor Bug will be here to do mental health for you. It's been a pleasure, guys.
Thank you.
Thank you.
You're very welcome.
on my dad's side. I'm also Dutch, German, English,
Hey y'all. If you could start making your way back to me, we will start our mental health portion of our HESI review. Come back to me, come back to me. And I'm the closer, so I've got big shoes to fill. Because I'm not too sure what you have already done, but I also have the privilege of being your current teacher, so there's not that much pressure. Not too much pressure. How's everybody doing? Doing okay? Long night?
I'm cold.
Me
It
too.
snowed here.
Oh no, that's snow. Well, I can't say snow. I just we live in a house that was, I don't know, built in like the 20 or I don't know, something. It's like one of those historical homes in here, in our little town we live in. And my husband walks in my office. He's like, "It's cold." And I'm like, "If you're cold, I know it's really cold," because he's never cold. But yes, it's cold. But I can't boast about snow.
Yeah, we got like 3 inches today.
3 inches of snow. Yeah, it was 45 degrees here today. It was 45 today, but it's been like 23 in the mornings and stuff. So cold enough, but not cold enough for inches of snow. But I am the last person, last professor. Yes, I did get your email. I was trying to get something in my belly before I came on and was stuttering for like a glucose. Yes, I got your email. Thank you for letting me know. And I'll get it notated as well. All right, so if I can get all cameras on for me. Go ahead. Somebody say something? No? I could have sworn somebody said something. All right. Devin, can you turn your camera on for me? Or if you can't, just message me. Oh, I definitely understand. Yeah. No, I would have never thought that. Never thought that. All right. All cameras on. We'll start. So I need full faces on camera. I know it's super late. I'm not feeling my best either. I'm glad it's an hour of professor time for each of us because I would not have survived our typical 3 hours and 45 minutes today. So if I can get everybody to turn the cameras on for me. Okay. You're precious. If I could get everybody to turn their cameras on for me, that would be fantastic. So we'll start our review. Make sure I'm recording now. Hey, Professor Bogart. Are you able to make me co-host so I can record? I don't know if she's there. Oh, it is recording. Sorry. I don't know why I didn't see it at the top. It is recording. All right. So for, I'm sure you have had most of your questions answered. Does anyone have any questions left after? It's weird seeing y'all at home instead of at school. I just realized some of you are at home. Does anybody have any questions, like leftover questions? I know Professor Prokovich started off with the HESI, the remediation hours, all those things. Remember, that's posted in our announcements. It'll drop, or it may have already dropped. All the due dates for your remediation are in the announcements, all those things as well. So any of your questions, have any of your questions not been answered?
DC, Freya, get your ass on that couch and go to sleep.
Nah, man, we just heard you cuss out your child.
I'm sorry.
Mute yourself. I'm not laughing. It caught me off guard. That's why I was smiling. All right. So nobody has questions. Y'all ready to just dive in? So what is the biggest, I guess, hindrance do you think would be for your mental health section of your HESI? Because you know that there's 3 parts, each 1/3. So 1/3 maternity, 1/3 pediatrics, 1/3 mental health. So what do you foresee as the biggest hindrance, maybe, or the biggest topic that you're like, ooh, I'm a little nervous about? Don't pretend like I can't talk, because on regular days, y'all like talk. Everyone's just gonna score at the wazoo. I believe it.
Honestly, I don't even think I am nervous about mental health.
Good. Good. I don't think you should be, but that's just kind of silly me saying I don't think you should be because I'm the professor and you're the student. But I just wanted to start it out if anybody had any particular questions about the HESI. So again, it's a third of each. And we have already gone over everything that you'll need to know for mental health. So I'm going to start out with a couple of practice questions. Everybody needs to be involved. That's part of your professionalism. There are 18 questions here, and there are 18 of y'all. So that's a question each. So everybody could get their professionalism grade if everybody did one question. This is different. This PowerPoint slide, I have set it up. You'll get it after class along with a very helpful HESI mental health document that prioritizes things that I think that you should know that are very, very important for the HESI. And so you'll get both of those. I set those to drop as an announcement after class as well. So you'll get everything I'm using today, you'll get after class as well. Remember also to go back to the exam review recording. Watch that. Get your notes out from when you took notes then, or if you were live. I think it was just me and Elizabeth, I'm not too sure. But get your notes out. Look at the review for the mental health exam. That will be much like your HESI. Look at your lessons. Look at your quizzes that you've had in the class. Look at your SIM charts. Those will be the types of questions that will be in your HESI for mental health. Nothing, no topic would be new, okay? Everybody has a drug sheet, right? Everybody has a drug sheet. It was in the announcements. Or not, it was not in the announcements, actually. It was in your email. I emailed it to you. I would print this out before next week, or print it this weekend, or print it at the beginning of the week, or whenever before you have your HESI for this class. I would print that out. Someone asked if there are going to be meds on there. Absolutely. But you only have a couple of drug classes that you're even going to need to worry about. Okay. What might those drug classes be?
Anti-anxiety, psychotic, SSRIs.
Benzols.
Antidepressants. So yeah, so anti-anxiety medications or benzodiazepines, antidepressants, antipsychotics, and your mood stabilizer. That's all, right? So not a lot. If I were to ask you to give me 2 anti-anxiety medications, what would you be able to do it?
Yes.
Name them.
Zoloft.
Oh, no, 2 anxiety medications.
A lot of bed. What's the pro?
You said Xanax or alprazolam. Okay.
A lot of bed.
And Klonopin. So Xanax or alprazolam and Klonopin. Got it. What about Buspar or Buspirone? Tell me about that drug. Is it an anti-anxiety medication?
Yes, and it's non-addictive.
And what else? So it's non-addictive. What else does it not have?
Sedative?
A sedative effect. Good job. Somebody say something. So it doesn't have a sedative effect. It's not addictive, and we can use it for long term. Can we use, or were we supposed to use Klonopin, Valium, Ativan? Were we supposed to use those long term? No. Do we judge? No. Do they have issues? Do those benzodiazepines have respiratory depression? Check mark yes. Do they have sedation? Check mark yes. Do they have sedation? Check mark yes. Okay. So the biggest issue with anxiety medications is what? What's priority always?
Respiratory depression.
Absolutely, respiratory depression. So it's just simple, just like that. That was your benzodiazepines, anti-anxiety medication. Xanax, Klonopin, Valium, Ativan. Those drugs cause respiratory depression, weren't meant for long-term use, and have a sedative effect and are highly addictive. The one that is not, but is still an anti-anxiety medication, is Buspar or Buspirone. It's not sedating, it's not addictive, but it still does the job. Tell me what neurotransmitter is associated with anxiety medications?
GABA.
It's your excitatory brake. It tells you to slow down. Okay. How many classes of antidepressants are there?
4.
4. I'm like, 4. Name them.
SSR,
SSRIs.
tricyclic, SSRI,
So name them. I want you to name them. So what's first line treatment? I'm going to go to it every time first.
SSRI,
SSRI,
And then
SNRI,
SRNI,
SNRI.
tricyclics,
Tricyclics. What's the last one?
MAOIs.
AOIs.
Mayo,
So SSRIs, SNRIs, tricyclics, and MAOIs. Tell me, tell me, gold line first degree medication I give is SSRI. So what does SSRI stand for?
Selective serotonin reuptake inhibitor.
So I'm increasing the amount of serotonin that's available. What does the neurotransmitter serotonin do? Somebody besides Stephanie. What does serotonin do?
Make us happy.
Mood, sex, sleep, overall well-being, even your fullness. So if you get a little irritable and you remember, oh, I haven't eaten since it's 7 o'clock over here. So I haven't eaten since 3 o'clock this morning or 4 o'clock this afternoon. Sorry, that's a long time. If I haven't eaten since 3 o'clock this afternoon, that's 4 hours of time I haven't eaten. I'm a little bit angry. I call it hangry. If I eat something, what occurs? My stomach gets full. And so my serotonin increases, just like Nzari said. My serotonin increases because I'm happy. My gut is full. So serotonin is your mood, sex, sleep, overall well-being, and even your state of fullness, or your gut satiation. How long does it take for all antidepressants to work?
4 to 6
4
weeks.
to 6 weeks.
6 weeks. Give me 2 SSRIs.
Lexapro.
Lexapro.
Zoloft.
Zoloft. Give me 2 side effects. Do you have to know every side effect of every drug? Absolutely not. What do you need to know? Major ones, just like I was saying for anti-anxiety medications, respiratory depression, no long-term usage, and sedation are the big 3. That's all you need to know. So with SSRIs, or selective serotonin reuptake inhibitor, I'm increasing serotonin, so I'm making myself more happy, making the patient more happy, better mood. Y'all said Lexapro, Prozac, Zoloft. What are side effects? Give me 3.
Headache, dizziness,
Headache,
dizziness,
cotton,
Nauseous, vomiting.
NVD,
weight gain,
nausea, vomiting, diarrhea, weight gain. What typically makes someone stop an antidepressant besides the weight gain, where they start to feel better? What's the other thing that makes them stop? What happens to their
Is it the sexual dysfunction?
sexual dysfunction? Or their sexual drive decreases, right? So that's the number one reason, other than weight gain, that individuals usually stop their medication, or they say, "I started to feel better." Well, you feel better, so continue to take the medication if there were no side effects, right? That's teaching point 2. All right, so SSRI, I am reverbing. I'm not now. Okay, SSRIs, SNRIs are next. What does SNRI stand for?
serotonin non-epinephrine reuptake inhibitor.
Perfect. Serotonin and norepinephrine reuptake inhibitor. So we know what serotonin does: mood, sex, sleep, overall well-being. What does norepinephrine do? I'm sorry. Think about fight or flight. Norepinephrine increases.
Triggers that, not triggers, it regulates the fight or flight stress response to the body.
So what does it do? Makes you alert and increases your concentration. Helps you figure out, am I going to fight or am I going to flee? Good job. If I can't see whole faces, then I can't, then there's no point of you being here. Give me 2 SNRIs.
Effexor.
Effects.
Acidic.
And Prestige.
Cymbalta.
Good job. Cymbalta, Effects, or Prestige. What's the other one that we talked about recently? That if I usually go gold standard SSRIs, but something else would make me go to SNRIs first. What was that?
gabapentin.
Was it gabapentin?
Yeah, it was gabapentin. So gabapentin is an antidepressant. It's an SNRI, but what do we use gabapentin for?
Pain.
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 Neuropathy. Good job. So we use drugs that target symptoms. So if I have pain, but I also have depression or low serotonin and low norepinephrine, then I can use that drug to treat all three of those symptoms. Does that make sense? Okay. I'm going to give everybody a second to readjust their cameras. Full faces on cameras. We have 45 minutes left. Promise. So those were SSRIs and SNRIs. The next one is T for third, so it's tricyclics. Give me 2 tricyclics.
Amitriptyline.
Amitriptyline, aka Elavil. Good job. Give me one more.
Cinequin.
Cinequin, aka
Cinequin.
Good job. Cinequin, aka Doxepin. Good job. And I don't care if you don't know how to pronounce them. Do I know how to pronounce every drug? Nope. What's my biggest thing? If you're on your HESI and you see Cinequin or Doxepin, or you see amitriptyline or Elavil, I want you to remember, yep, that's a tricyclic. It's a type of antidepressant. And I don't really want to be in this category, but if I'm on the drug, that's fine too. But why don't I want to be here? What are the side effects?
Constipation, dry mouth.
Anticholinergic.
Yeah,
Urinary retention.
so anticholinergic effects. So everything gets dried up. So just like everything you were saying. So dry mouth, urinary retention, blurred vision, sexual dysfunction, constipation, orthostatic hypotension, low blood pressure, abnormal heart rhythms. So I don't really want to be at a tricyclic, but if it's the antidepressant class that works for me, it works for me, right? What's the last antidepressant drug class?
MAOI.
MAOIs. What does that stand for? Does anybody know what it stands for? Monoamine oxidase inhibitor. Monoamine oxidase inhibitor, MAOI. What does an MAOI break down? What chemical?
I'm sorry.
So if someone said they didn't hear me. So monoamine oxidase inhibitors, that's what MAOI stands for. Monoamine oxidase inhibitors break down a chemical. What's that chemical called? Someone said it. Tyramine. Individuals who have a diagnosis of depression and are on antidepressants, the antidepressant, any MAOI, Nardil, Marplan, Parnate, or MSAM. Nardil, Marplan, Parnate, or MSAM. Any drug like that, they need to stay away from foods containing tyramine. What types of food contain tyramine?
Wine.
Food, pickled food.
Salami, they got salami.
Charcuterie board. Remember the charcuterie board. Can I have cameras on unless you have told me where you're going? I mean, I'm not asking a lot of you, just one last hour. Monoamine oxidase inhibitors. They break down a chemical called tyramine. Tyramine is present in aged, pickled, smoked, brined, aged foods. Think of a charcuterie board. We just said this recently in class. Think of a charcuterie board. Salami, pepperonis, figs, any dairy, right? Yogurts, chocolates, avocados, things like that. Give me the major side effect for MAOIs.
Hypertensive crisis.
And what exactly does that mean?
High blood pressure.
High blood pressure.
Is it like your rays are like, oh no, let's go? Or is it
on the severe end that could cause like cardiac arrest?
Absolutely. So it is a medical emergency. So you immediately stop the medication, you get them medical treatment. If somebody walks onto your unit up to you and says they have a headache, what do you do?
Check their blood pressure.
Check their blood pressure.
Vital signs.
Yes, that's correct. What's your rationale? What is that giving you?
Wait, obtaining, why did we obtain the vitals?
Yeah, so obtaining vitals is the correct answer. Correct, yes. What's the rationale for doing that?
Like if you know they're on advanced medication and they're coming with a headache, typically with a headache, it could be like their blood pressure is extremely high.
So the rationale is you're gaining information. You're gaining objective information. And that's what we need to figure out what our next intervention is or what our next action is. Good job. So anti-anxiety medications, antidepressants, 4 types. Know them in the order that we said them in because it's that much easier to understand them. What other drug class do we need to worry about? There's 2 more. What's the one that we use for bipolar disorder?
Mood stabilizer.
Mood stabilizer. And what's the only mood stabilizer?
Lithium.
Lithium is a natural salt. Where sodium goes, water follows. What do we need to do with our water intake?
Keep the same.
Keep it the same. What's the rationale?
Because where
salt
goes, water goes.
Whenever
They all go the same place.
goes, water follows. We want them hypernatremic or hyponatremic, and we want that lithium level to be a certain therapeutic range. What is that range?
0.4 to 1.5.
Yeah.
0.4 to 1.5. Anything over 1.5 is considered toxic. Give me toxicity symptoms for lithium.
Confusion. Tremors. Lack of coordination. Diarrhea, vomiting.
Nausea, vomiting, diarrhea, loss of weakness. Good job. What's the last drug class that we need to worry about?
Is it antipsychotic?
Antipsychotics. How many generations are there? 2. First generation antipsychotics are the oldest. Do we want to use these? Not particularly. And what's the rationale? What do they have major issues with?
Side effects.
What's that term that we use to collectively call 4 symptoms?
EPS.
EPS. And what 3 do I want you to know the most?
Akathisia, tardive dyskinesia, and dystonia.
Good job. And somebody besides Elizabeth, tell me what akathisia is. Restlessness, pacing, inability to sit still. What is tardive dyskinesia?
Lip smacking.
Lip smacking, movement of the lip. Good job. Movement of the lips, jaw, lip smacking, tongue protruding, popping your jaw in and out of place. What is the last one? Dystonia. What is that?
Muscle distraction.
Sustained muscle contraction. Good job. So you can remember my young fellow who rolled his eyes in the back of his head. He didn't. The Haldol did that. Or my older gentleman that had been on Haldol for years, and his chin ended up being, remember, on the side of his shoulder blade. Sustained contraction like that. Over time, it just stayed like that. Unfortunately, he couldn't get it to turn back. Very good job. Give me 2 examples of first generation antipsychotics.
Haldol.
Prolixin. Good job. Second generation antipsychotics. Give me 2.
Abilify.
Abilify and Seroquel. Good job. I like Risperdal or Zyprexa, Geodon. What are those side effects? Less than first generation for sure. But what?
Drowsiness.
Blurred
vision.
Weight gain.
Dry mouth.
Function. Dry mouth. Good job.
And
go ahead. I'm sorry. Somebody say
never mind.
Okay. We give drugs to target symptoms. What's the rationale for me being able to give an antipsychotic to someone who has bipolar disorder?
Can you repeat that, please?
So we give drugs to target symptoms. What's the rationale for me to be able to give somebody an antipsychotic if they have bipolar disorder?
Hallucinations.
Okay, hallucinations. What else?
Mania.
Yeah, and what are mania symptoms? Impulsivity, compulsivity, aggression, agitation, irritability, right? So that's why we're giving that drug. Good job. Questions about your drugs. That's the basis of it. That is about as in-depth as it's going to get. Questions about your drugs. Okay. There are 18 of you all, and there are 18 questions. So everybody gets one as your professional grade. This is going to be a little bit different because let me see what it looks like on my screen. You are going to read the question. I'm going to ask you a question and you're going to answer the question. Okay. Everybody has to participate. All right. Here we go. First person up. Anybody wants to go? Go ahead. They're easy ones.
Me, I volunteer.
Go ahead.
So a nursing student is caring for a patient admitted with depression during their first interaction. The patient asks, "What kind of help can I get here?" The student explains available services and begins discussing the patient's concerns. Which phase, because I can't say that word, I ain't even gonna hold you.
PEPLAL.
Nurse-patient relationship is occurring.
So PEPLAL is
PEPLAL, you said?
Hildegard PEPLAL is a nursing theorist. Because of her, we have the 4 levels of anxiety: mild, moderate, severe, and panic. Because of her, we have the mental health specialty. Because of her, we have the nurse-patient relationship, which is the most important part of your nursing career. If you can't bond with a patient or build rapport, you're not going to get very far in your nursing career. Be a Debbie Downer. That's just to say you have to learn how to talk to people. You have to learn how to be professional, and you have to learn how to carry yourself and be a person that has good ethics, morals, and values. So, if Hildegard Pebble also made the stages of the nurse-patient relationship. These are the 4 stages of the nurse-patient relationship. We didn't discuss in particular Hildegard Pebble, but you can still answer this question. So, if we have our first interaction, keyword first interaction. You guys need to learn how to break down questions on your HESI. This is our first interaction together, and the patient asks you, the nurse, what kind of help can I get here? And then you start explaining all the resources that we have at your hospital. What phase is that? Narrow it down. Go ahead. What is it?
Orientation phase.
Orientation phase. And what's your rationale? If you can give me a rationale, I know you're not guessing. I know you're critically thinking. So it is orientation phase. So how do you get to orientation phase?
Yeah, you need to orient the patient for the patient to know where to know where the restroom is, where to get food, where to get everything. Yeah.
Yes.
So you orient the patient.
Good job.
For the patient to know where to go when he needs something.
Absolutely. Spot on. Good job. So D, resolution phase. Have we resolved anything? No, they asked a question. So D is automatically out. So even if you knew nothing about PEPLAL, and you knew nothing about this nurse-patient relationship, which stage are we in? We're past pre-orientation, right? Because I already have the patient on my unit. Pre-orientation would be before I got my patient on my unit. Pre-orientation would be before you got admitted to Fortis. What did you have to do to get here? Your high school transcripts, the colleges that you've been to previously, your application, your application fee, all those things, right? That's pre-orientation before you even get your foot in the door. The orientation phase is what we're doing here. You having questions answered. So the orientation phase, you are accepted onto the unit, aka into Fortis. And they have the senior class come in and tell you all the tricks and tips that you need to do to be successful, right? You get your scrubs, you get your books, you get your syllabus, all the things. C, the working phase. What does that sound like? Don't make it hard. It's the work. For nursing, it's the interventions. For nursing school, it's doing your homework on time. It's communicating effectively. It's doing therapeutic communication. In nursing world, it's working with your patients doing the nursing interventions. In the resolution phase, that's discharge. So do you see how even if you didn't know who the heck PEPLAU was, you can still get this question right? Make sense? All right, good job. Next. Devin, you're off the hook. Good job.
A patient experiencing moderate anxiety is having difficulty concentrating during patient education. According to PEPLAU's theory, what is the nurse's priority intervention?
So before you answer, again, it's PEPLAU. You're like, I don't remember who that was. We didn't particularly go over her. And that doesn't matter. I did this on purpose. It doesn't matter. What we need to know is we did go over anxiety. Mild, moderate, severe, and panic. So don't psych yourself out on the HESI if you see something. Oh, we didn't go over that. There's context clues here. So moderate anxiety, mild, moderate, severe, panic. So that's pretty good anxiety right there, right? Mild anxiety, that is helpful and beneficial. Moderate anxiety, we start to actually feel like the symptoms of anxiety, right? What might those be? Give me two symptoms of moderate anxiety. Anybody?
Breathing,
rapid heart rate.
Rapid breathing, rapid heart rate. Anytime you get asked a question about symptoms of anxiety, think about your physiological symptoms. What happens to your respiration? What happens to your heart rate? What happens to your blood pressure? Things like that. Always remember that, okay? So, even if you didn't know PEPLAU, we know that a patient's experiencing moderate anxiety, and you're trying to give them patient education. As the level of anxiety increases, the ability to concentrate and make decisions decreases, right? You have horse blinders on. You are only able to think about whatever you're worried about, right? Think Maslow's. Can higher needs emerge if lower needs are unmet?
No.
Can basic education or learning be committed and done without physiological needs being met?
No.
No. So what's the correct answer here?
B.
B. Implement interventions to lower anxiety before continuing education. We're never going to postpone all teaching until they're completely calm. That means you're doing nothing. You will never not do something as a nurse, right? We're not going to postpone. We're not going to stop. So C is out. Provide written materials for the patient to review independently. Yeah, because that's their job, right? No, it's your job to educate. It's your job to make sure that they understand. So D and C are out. Continue teaching as planned, since learning can still occur. That's not true. Learning can occur. They're going to be focused on the stressor, and they're not going to be able to understand anything that you've said. And you completely negated the fact that they need help, right? So the answer is B. Good job. All right, Stephanie, you're off the hook. Next.
A patient who recently lost their job states, I feel like such a failure. I don't know what to do. Which response by the nurse is most therapeutic?
So before you ask that, what's the patient doing? They're telling us how they feel. I feel like such a failure. I don't know what to do. Do we ever give advice?
No.
Do we ever give?
But you want to validate.
Right. We always validate. Which one of these provides validation?
C.
C.
C. You look worried. Tell me more about your experience, what you're experiencing. Don't worry. Everything will work out fine. That's false reassurance. Do you know everything's going to work out fine for them? No, you don't. And if you do, I want to know how, because is everything going to be okay with me? Let me know. You should start applying for new jobs right away. You just negated them telling you they won't even talk to you anymore after that, right? You've completely negated the fact that they were trying to tell you something very, very important. I feel like such a failure. I don't know what to do. And your therapeutic response is you should start applying for jobs. No, that's not helpful. They need to work through their feelings first. I felt the same way when I lost my job last year. If you tell your patient that's become a social relationship, not a therapeutic relationship. And all your relationships with your patients should be professional and therapeutic, not social. If you're able and you feel comfortable enough to tell your patient that you felt the same way when you lost your job last year, you have encountered countertransference. That means you're putting your feelings onto the patient. Okay. We should never be doing that. So you look worried. Tell me more about what you're experiencing. That's the most therapeutic response ever. You're validating that they feel like a failure. You didn't say they were a failure. You're validating that they feel like a failure. You're validating that they don't know what to do, and it's okay not to know what to do. You just got fired, okay? You look worried. Tell me more about what you're experiencing. That's an open-ended statement that says, hey, I'm listening, okay? Good job. Good job, Brian. You're off the hook.
During the therapeutic conversation, a patient suddenly becomes quiet and looks down for 20 seconds. What is the nurse's best action?
So is nurse card, is 20 seconds a long time?
No.
Not really. It feels like it though. Like if we were having an intense conversation, like you were asking me all the things about my life and you're getting all this information, and then you suddenly ask me a question and I just like stop and pause for 20 seconds. It might seem like a lifetime for you because we've been talking, right?
Mm-hmm.
But 20 seconds is not a lot of time. Do we ever ask why questions in mental health? Never. Never. Do we ever want to change the subject? No. They are quiet for a reason. What do you think the quietness comes from? You might be the first person that has ever asked them a question that makes them feel like they are being seen. How was your childhood? Did you feel love in your house or your household? That might be a hard hitter, heavy question, right, for somebody. And if they stop talking for 20 seconds and look down and are quiet, they may be really searching their mind from like, I am 36. I might be like, ooh, my childhood, did I feel loved? Of course I did. Yeah. Wait. There was that one time my dad like popped me one time. Like, oh no, but that was just love. They might literally just be inner dialoguing, right? So what's the answer?
C.
We're going to wait quietly and allow the patient time to gather their thoughts. We're never going to feel silence. Silence is good. That means they're reflecting. You'll know when silence is like, I'm not going to answer your question, or when silence is, you've asked me a heavy hitting question and I need to like pause for a second so I can be really real and vulnerable with you, right? It's like going to therapy and you're like, this is not working. They're just bringing up trauma after trauma. And they finally ask you a question. You're like, ooh, that hit. Like, oh, okay. So yes, we're going to wait quietly and allow the patient's time to gather their thoughts. We're never going to change the subject so the patient doesn't feel uncomfortable. We need them to be uncomfortable, right? To work through hard emotions, right? Good job. You're off the hook. Next.
A client with an anxiety disorder reports attending yoga classes twice weekly and journaling daily about stressful experiences. These behaviors represent.
Right, don't answer. First of all, I just have to say, like, I was on TikTok before I was on TikTok earlier, and this girl did her little microphone like you did. So I'm just laughing because you're talking into it. It's just funny. But let me ask you a question. If you have an anxiety disorder and you're attending yoga and you're twice weekly, and you're journaling daily, is that helpful?
Yes.
Yeah, we want them to be doing those things, right? Those are good, healthy interventions. Those are called adaptive interventions. What does maladaptive mean? Negative or bad, right? Mm-hmm. So can we automatically eliminate A because we know that's silly? Yes. It's not negative emotion-focused coping. It's not negative. So A is already gone. What about C, avoidance coping? Does that even make sense?
No, because it's not like she's avoiding anything.
Absolutely. She's doing she or he is doing what they need to do, so they're not avoiding anything. So you could automatically read the question, think about it, eliminate what you know to be wrong, A and C. If you can eliminate one thing, you can eliminate two things. So A and C are automatically gone just because they don't make sense. This is how I want you to be on your HESI. So you've got B and D left. Now, Elizabeth, tell me what the correct answer is.
Adaptive emotion-focused coping.
And what's the rationale? Because what does that even mean? What does adaptive emotion-focused coping mean? We went over it in class. It was on your exam. What does adaptive emotion-focused coping mean?
You're channeling that energy into something else, something helpful.
Yes, adaptive means good or changed. So good emotion-focused coping. I would say that attending yoga weekly or twice weekly and journaling daily about your experiences is emotion focused and it's healthy. Problem focused coping does exist. Give me an example of problem focused coping. That would be me saying, I have a hard time with time management. That's a problem. So, problem focused coping would be getting out a calendar and writing down my duties as a professor in red, my duties as a wife in purple, and my duties as a individual in a different color. Right? That makes sense. That's problem focused. It helps me figure out what I need to do, which role am I stepping into on which day, depending on the colors. Does that make sense? It solves my problem of being unorganized, right? So that's problem focused coping. And that is a thing, problem focused coping. But this is adaptive emotion focused coping because attending yoga and journaling are emotion focused. Make sense? Okay. Next, you're off the hook, Elizabeth.
A patient describing feelings about a recent diagnosis. The nurse maintains eye contact, nods occasionally, and says, "Go on," when the patient pauses. This demonstrates.
So if I am looking at, when we talk about therapeutic communication and building rapport, how do you expect someone who cares about you and you're telling a story to look at you? Would you want them with their back turned to you? Would you want
Making eye contact?
So eye contact. And with cultural relevancy stuck in there, right? Like look at them. So you want eye contact. You want them occasionally nodding or making like, go on, right? You want them to encourage you. That's what this sounds like, right? I pause occasionally when the patient pauses. I tell them to go on. I'm nodding. I'm maintaining eye contact. So I'm basically telling them what? Hey, I'm listening. What's the correct answer?
B. Active listening.
Active listening. And these are the type of questions you'll have on your HESI. It's not hard. Take a deep breath. It's not hard. Good job. You're off the hook. Next.
A nurse is caring for a patient in crisis who expresses suicidal ideation. According to the crisis intervention principles, what is the nurse priority goal?
Priority, priority, priority. Crisis intervention. Suicidal ideation. Someone says, I am having thoughts of hurting myself. What is priority?
Safety.
Is it going to be B?
Safety. It's going to be B. So B, safety. Safety first, safety second, safety always. After safety, it's airway, breathing, circulation, or your ABCs. After your ABCs, it's Maslow's physiological needs. I can't talk to you until I feel safe. I can't talk to you until I have appropriate airway patency, until I'm breathing effectively and I have good circulation. And I really can't talk to you unless my physiological needs are met. Food, sex, sleep, water, homeostasis, excretion. I can't do anything. So B, ensuring patient safety through external controls. External, it means you controlling their environment. Are you going to automatically stay one-to-one with this patient because they express suicidal ideation? Of course. Of course. Do we ever leave a patient alone who is experiencing a crisis? No. Rationale. Safety.
For their safety.
Their risk for harm for themselves or others, right? Good job. You're off the hook. Next.
A parent with schizophrenia or appears to be listening to something. What is the nurse's most therapeutic response?
Now, did Ms. Sims, did we talk about schizophrenia directly in class? No, we had chapter 17. That was drugs used for psychosis in week 1, I believe, right? Mm-hmm. She's like, I'm just gonna go with what you said. So I'm saying,
no, we didn't. I know we didn't talk about schizophrenia.
See, but we did talk about drugs for psychosis because what kind of drugs do we use for psychosis or schizophrenia? First and second generation antipsychotics, right? Good job. Right. So, do we ever play into someone's delusions or hallucinations? Never.
No.
Never. Do we ever tell them that they're just imagining things or making things up? No. What's going to happen? They're going to shut down on you and they're probably not going to talk to you or tell you when they are actually having issues, right? We want them to be able to be honest and open with this. But what's the most therapeutic response?
B.
B.
C.
Yes, correct.
No, I
Okay.
said B.
It's
I
actually
was at B.
It's B.
Okay.
Mr. Gardner, you seem to be listening to something. I'm not hearing any voices. Come and talk to me. So you're acknowledging, hey, I think that you're talking to somebody or seeing or hearing things I'm not seeing or hearing, but you're saying in a very polite way, matter of factly, but you're also telling them that you don't hear any voices, so that's ensuring safety. Come and talk to me. That's getting their mind off of that internal source, okay? Does that make sense? Now I know C looks real juicy, where the voice is telling you, but does that automatically, it says appears to be listening to something. Do we know that it is a command auditory hallucination? Because that's what that was called. No, we don't. They just appear to be listening. They could be literally listening. There's no context to this question, and we don't need to put context to the question either. The answer is just B. But if this question had more information, the patient is sitting in the day room where other patients are, and you look over and the patient who has this diagnosed schizophrenia appears to be listening to something. They could be listening, trying to eavesdrop, right? But it didn't give us any of that information. All it said was they appear to be listening to something. What's your best therapeutic response? If you say, what are the voices telling you? You're assuming that they're hearing voices, right? You're putting that into their head, right? We don't want to do that. We don't want to assume, because that makes a blank out of you and me, my grandmother used to say, right? And we're never going to ignore behavior to avoid reinforcing it. Ignoring behavior does nothing. Do you have a child? If you have a child and you ignore behaviors, what happens? They get worse typically, right? Unless they're tired enough to like stop doing what they're doing. So the answer is B, okay? It gives validation. It doesn't play into what they're potentially seeing or hearing or listening to, but it does give them a person to come talk to instead. It takes their mind off that voice. Okay, make sense? Good job. You're off the hook. Next.
A patient with bipolar 1 disorder is admitted to the psychiatric unit with assessment findings are most consistent with the manic episodes. Select all that apply.
Destiny, what does bipolar 1 disorder even mean?
It's not manic.
It is manic.
No. For 1 and 2, it is manic, so it's more like a crisis. Or
so yeah, tell me what bipolar 1 disorder means. What do they have? What 2 symptoms?
As far as
they have mania and they have depression, right? Bipolar 2 disorder has what?
Now, Brad has a successful drug dealer spent in winters in the south of France.
Anything. What does bipolar 2 disorder have?
It's not manic. It doesn't have mania, or it doesn't have the auditory part.
All right,
no hypomania.
Yeah, there you go. Hypomania and depression. So with bipolar 1 disorder, 1 episode of mania gets you bipolar 1 disorder. So bipolar 1 disorder has mania and depression. Bipolar 2 disorder has hypomania, or simply euphoria, and depression. So bipolar 1 is always going to be mania and depression. Bipolar 2 disorder is always going to be hypomania, or a lessened form of mania. I just call it euphoria. They feel really, really good. They can't tell you why. And then depression hits. Okay. So this is a select all that apply question. So which assessment findings would be most consistent with manic episode? So you need to think back and say, okay, what does manic behavior look like? What do we talk about in class about bipolar disorder and mania? Now,
they're all to go.
Yeah, they're sitting on G, waiting to know, never stopping. So what is the answer here?
A is one of them.
A is
B
correct.
is one of them.
B is correct.
D is one of them.
D. That's it.
That's
right?
it.
So
I was reading them, but yeah, that's it.
Yeah, A, B, and D. So reports not sleeping for 3 days. Individuals who have mania don't sleep. Most of the time when you finally get to them to the hospital, they've been up for 3 to 7 days, okay? They don't eat either. They don't sleep either. So C is out because hypersomnia means a lot of sleep. So that's why C is out. They do speak rapidly and they jump between unrelated topics. That's that manic behavior. They start projects and they don't finish them. They start and stop things. They never finish projects. Grandiose statements about special powers. That's D. They have delusions of grandeur. That's what they're called, delusions of grandeur. Most of the time they think they're somebody special or they're a celebrity. If I had a flat affect with minimal facial expression, that has nothing to do with bipolar disorder, right? That would actually be, well, it could, but that would actually be the depressive part of the episode, right? Okay, good job. You're off the hook. Next.
A patient experiencing mania has lost 8 pounds in 1 week. What is the nurse's priority nutritional intervention?
So an individual who has mania has lost 8 pounds. They don't eat. They're constantly on the go. They don't sleep either. So what's the best way to make sure that I get nutritional intake?
B.
B, offer small, frequent, high-calorie meals and finger foods. If I can dabble in your turkey sandwich or dabble in some crackers or dabble in some chips or a juice box or something, that's a lot better than expecting me to sit down for 3 large, well-balanced meals. I'm not going to eat, okay? I've got to be up and on the go. We're never going to just provide nutritional supplements only. That would be like counterintuitive. We're not going to restrict food either. That would be inhumane, right? Let's do a pulse check and make sure I see everybody's faces. We're almost done. We have 10 minutes left. Shirley. All right, next.
A nurse suspects intimate partner violence in a patient presenting to the emergency department. What is the nurse's priority action?
So intimate partner violence. This is outward focused emotions, aka violence. Are we ever confronting someone?
No.
We're not detectives. Do we ever ask the patient about abuse in front of the partner?
No.
What would that do?
No.
Make them lie.
Right.
We won't get a straight answer. So B and C are left. What's the correct answer?
B.
Interview the patient privately without the suspected abuser present. Why, and yes, I'm not saying why is C incorrect?
Because as healthcare workers are mandated reporters, we can't just turn a blind eye.
Yes. We can't just document suspicions but take no actions without proof. We feel it, we believe it, we report it. Worst case scenario, we're wrong, which is actually a good case scenario because we don't want anybody to be being abused, right? So we do best case scenario is we simply report what we see with the proof we have. If we didn't have proof, well, then we shouldn't suspect abuse, right? Our brain should be saying something is off here. This is my assessment finding why I feel like it's off, and this is why I'm reporting it. Make sense?
Right.
Okay, good job. Next, you're off the hook. Good job.
A nurse is counseling a patient experiencing IPV about developing a safety plan. What is the most important element to include?
So intimate partner violence, again, outward focus emotions, aka violence. So what is the most important thing that when you're developing a safety plan, you're helping them come up with ways to escape? They may not be ready to leave the relationship just yet. It's hard to leave a relationship. There's security there, even though there's also threats there and fear there. There's a certain amount of love there, despite all the things that has gone through with the relationship, I'm sure. There's a lot of things that are binding those two people together for reasons we don't know and reasons that we're not going to judge. But when they're at a point where we can develop a safety plan, what is the most important thing that we need to include?
I was going to choose B.
B, correct. Say it with your chest because it's right. Signs of escalation in a predetermined escape destination. Meaning, let's say typical pattern of the abuser is to throw things, cuss, yell, Name call. Well, if we already know that, then that means that they're escalating, right? So, number one, when he or she starts to blank, that means that the violence is likely going to occur. Check mark. What is a predetermined escape destination? Who can you trust? Where can you get to quickly? And who can help you out? Makes the most sense, right? I am allergic to coconuts. If I was in a intimate partner violent relationship, and let's see, Professor Bogart was my best friend, I am going to let her know, like, hey, I should have told you a long time ago, but I'm in a violent relationship. I'm in a domestic violent relationship. I'm not ready to leave him just yet. I don't know why. Don't ask me that, Professor Bogart. But if I'm definitely allergic to coconut. So if I send you a simple emoji of a coconut, you know to automatically call the police because I'm in a situation where I can't do it myself. Does that make sense? Okay, good job. You're off the hook. Next.
Which patient behaviors indicate rape trauma response? Select all that apply.
So this is, again, outward focused emotion, violence. An individual has gone through any kind of traumatic experience. What is their life going to be like afterwards? Select all that apply.
A.
A for sure. Emotional trauma. Absolutely.
B.
Disorganized lifestyle. Absolutely. They're not going to know up from down, left from right.
D.
D.
E.
Long-term reorganization process. Absolutely. They're going to be in such a state of panic and shock and a range of emotions that, of course, they're going to have trauma symptoms. Of course, they're going to have a disorganized lifestyle, and they're not immediately going to return back to normal functioning. They need long-term reorganization help, and you're going to help them through that, right? Good job. Next.
A sexual assault survivor arrives at the emergency department. What is the nurse priority action?
Are we investigators? Are we detectives? Are you going to school to be a detective? No.
Mm-mm.
Okay. Do you call the police? No.
Mm-mm.
Because this is an adult, and this is, let's say, intimate partner violence. Maybe they don't want to press charges. Maybe they have no idea who did this to them, right? So we're not contacting law enforcement to file a report. That's not your priority action. Your priority action is them and safety. So what's the correct answer?
Would it be B?
B, ensure the patient's not left alone and provide for privacy. Now, does providing privacy mean that we shut the door on them and leave them in the room by themselves? No.
Mm-mm.
It means we say, hey, I am Nurse Bug Cutler, and I cannot imagine the things that you have gone through. All I can acknowledge is that it's a very traumatic experience. I hate to hear that this has happened to you. Would you mind if I just sat in the room with you? If you need something, we don't have to talk, but if you need something, you can just let me know, okay? And then you provide privacy by sitting away from the bed or where they're sitting, but definitely get them out of this is like the emergency department. You know how they have beds in the hallway because we're overflow, right? They need to be in a room. They don't need to be in the overflow section, the outside of the hallway. Does that make sense? Good job. You're off the hook. Next, who hasn't gone? There's 18 students, 18 questions.
At the emergency department intoxicated. What is the nurse priority intervention?
So somebody becomes intoxicated. What is priority period? So safety first, safety second, safety always. Then what?
ABCs.
ABCs, airway, breathing, circulation. So what falls under that category here? What answer?
C.
C, monitor cardiac status and respiratory function. What's the rationale? Respiratory depression and
ABC.
good job, yeah, ABCs. Respiratory depression is a huge issue here. And their heart status, right? They can go into DTs. With the last time they drank, we have no idea. They can have delirium tremens. Good job. You're off the hook. Next and last, I believe. Only one person hasn't gone. Only one person hasn't gone. I'm pretty positive. So let's go ahead and get it going so we can leave here.
When assessing a patient for suicide risk, What is the most therapeutic nursing approach? Should I read the answers?
What did you say?
I want to know if I should read the answers too.
Oh, no, you don't have to do. No.
B.
B, be direct and non-judgmental when asked about suicidal thoughts. You want to be direct. Are you having thoughts of self-harm? Do you have a plan? Did you have a plan yesterday? No, I don't have a plan today, but I had a plan yesterday. What was your plan yesterday? Because we got a whole 24 hours, and so that thought can creep back in, right? Next, you're off the hook. Good job. Miss Berry, go ahead.
A nurse is screening a patient for alcohol abuse. Which assessment tool is most appropriate?
So alcohol abuse. What can we automatically eliminate? D. What does that say? Beck depression inventory. Depression inventory. Inventory means you have stock. So that Beck depression inventory is asking how many depressive symptoms do you have in your inventory? So we can eliminate that one, right? Correct. So I have A, B, and C left. Can we eliminate B? Glasgow Coma Scale. Of course, because what is the Glasgow Coma Scale rate?
Their consciousness.
Their level of consciousness, right? So A and C are left. What does a mini mental status examination do? You've read about this. This is chapter 9. What kinds of questions does it ask? Is your mood and your affect congruent? What are their speech patterns? Do they have thoughts of suicide? Is that going to be helpful for someone who has alcohol? You're screening for alcohol abuse. No. Cage questionnaire. Cage questionnaire. So even if you had no idea, you should remember what A is. But remember too, we have never talked about B and we've never talked about D. So use that to your advantage. If we didn't talk about it in class, you didn't read it in your book, it wasn't in a lesson assessment or a quiz or a SIM chart, then it's not going to be in your exam. No one's here to trick you. The HESI is the HESI for a reason. It's just a HESI. It's another exam. So if we didn't talk about it in class, I wouldn't lead you down the wrong path. So B and D would automatically be out. And you already know A because it's in chapter 9 and we talked about it in class. We know that the mini mental status examination has nothing to do with alcohol abuse screening. So process of elimination only is going to be C. Cage questionnaire. Make sense? Okay, last question. After administering naloxone to reverse opioid-induced respiratory depression, what monitoring protocol should nurse implement? Do we ever implement only excuse me, professor? Yes, correct. B. Evaluate the patient every 15 minutes for 2 hours for respiratory depression. Good job. All right, how do you feel about mental health? Fired up. Okay.
Good.
All right, have any questions for me? All right, after class drops, you'll get that PowerPoint and you'll also get, I want to show you really quickly. You'll also get this little document it's a quick reference sheet. Core concepts to remember, things about anxiety, depression, bipolar disorder to remember, things about psychopharmacology, think about your key med groups, antidepressants, benzodiazepines, your mood stabilizers, and your antipsychotics. Think about EPS symptoms, what are those? And then remember, know at least 1 to 2 teaching points per med, and that really just means what are the main side effects for the drugs. MAOIs, hypertensive crisis. Make sense? Okay, you'll email me if you need something. Never too late to go over your exam. Easiest way to study for your exam, for your HESI, is to get what you missed on your exam. Shoot me an email and say, hey, I'd like to go over my exam, even though y'all made really good scores. I want to go over my exam so I can see what I missed, because if you knew what you knew, why study what you know? You need to focus on what you didn't know. Make sense? Easiest way to study. Go back to your mental health exam recording review. Easiest way to study. Look at your notes from that. Don't make it hard. Don't overwhelm yourself for a HESI. Got it? I'm here. Let me know what you need, okay? This recording will You're welcome. This recording will be posted, your attendance will be taken, all the things. So if you need one of us, just let us know, okay?
All right, thank you. Good night.
Have a good night.
Good night.
Bye. Good night, y'all.
Bye.
Bye.